Okay, we're good. Thank you.
Okay, and I'm unmuted. These are bonuses here this morning. Okay, so welcome, January 16th of 2025. Happy New Year. First meeting of 2025. So why don't we go ahead and start with, should we do roll call first?
Roll call,
Yeah. So can you do that for me, Daphne?
You bet. Antoinette is by phone, so we'll save her from unmuting. Brian Duty.
Thank you.
He's going to be late. Mary Engrove. I don't see her yet. Holly Jo, we know you're here.
Mary, I thought I heard Mary.
Yes, I'm here.
Let me
Mary
check.
Engrove is present.
She is.
Yeah,
Yes.
she's here.
She is on the phone in the room.
Okay.
So,
Thank you so much. I'm not seeing that. I'm a little rusty, having been gone for a while. Adrian Irwin,
Here.
Max Kaiser,
Here.
Dr. Max Kaiser, Lucy Langer. And Lucy's calling in, should be here.
Is it Sarah?
Sarah Love.
Sarah Love,
I'm here.
Chris Benzon. Catherine Schabel, not here yet, and David Sanger is absent today. And Antoinette will be here soon, in person. Thank you, and there's Lucy, and I'll promote her right now.
Okay. And
So we do have a quorum.
Thank you. We're expecting Brian and Katie.
Yes.
Brian's having some car issues. He said he'd be late.
Oh dear, okay. But we haven't heard from Katie or Chris?
Chris Benzon is on.
Oh, she is.
Chris is online.
Sorry, I'm here. I was just late to unmute.
No problem.
Present.
I was just missing you already, so I'm glad you're here. All right, so that's great.
My notes say that Catherine Schabel will be here.
Beautiful. Okay, then let's move right along to the staff report, starting, I believe, with Jason.
Okay, so we have a number of items. First of all, a change to our protocol. I was invited to attend a training from our Ethics Commission, and one of the things that came up is a requirement for a roll call on all votes. And so what we're gonna do, since some people are online, we wanted to continue to use the chat, but we do need to make sure that we have a vote from everybody who's present before we move on to the next item, and a clear voice vote, and then we'll just roll call in the room. We will hope that works well, efficiently, but it's a requirement, so we need to do that. Secondly, legislative update. Liz, have any bills dropped? I've been out of the country, so I will be surprised as well.
Bills have dropped. Legislative Assembly is in session. It's the 83rd Legislative Assembly. There are a couple of bills concerning HERC, but no movement. There's one on the studying, phasing out prioritized list. It's a study bill. Others that tangentially relate to HERC, like a couple of notwithstanding bills. Other than that.
But not anything really detailed that we need to report on today, but of course,
Not
it's
today.
early days. The
Not
vote
today.
just dropped Friday, and we will see what happens.
The long sessions they have.
It's a long session.
Right, and the actual session doesn't start until Monday and runs through June.
I think
Sounds about right.
it begins, yeah.
I don't think it's truly been out yet. That's what I told you.
Okay, and then we have a new webpage. Liz, if you could bring up our new HERC work plan webpage. Since we are under scrutiny for the benefit update project, we wanted to be super transparent with everyone about our work plan for doing this, that we've committed to updating this at least once a month. I'm guessing it will be more than that. But this is the work plan, and you can see there we have the specialty area on the left, the key discussion items. So these are the ones where we think it may be controversial, it may be costly, it may you
High
know,
public interest.
high public interest. And so we've listed those. We haven't listed all the other nitty-gritty details that we believe are more straightforward, but we also have the date on which we expect to publish the meeting materials and the date on which we expect to discuss them at the meetings. As a part of that, you'll notice on that list, some of the dates are not dates on which the VBBS meets. Welcome, Katie. Katie Shabel has arrived, so we have 8 now. Sorry, where was I? Oh, the evidence-based guidelines subcommittee, EBGS, is going to be helping with some topics starting on February 6th. That'll be something new for them. We'll probably spend some time orienting there. So we've got a good strong group of people, and look forward to seeing what they come up with. So those items will not come to this group, they'll just go straight to HERC. So we just need to do that to kind of multi-thread, as they say.
Yeah, we're using all of our groups, and if any of the topics that go to EBGS are something that you have a lot of interest in or specialty in or whatever, you are more than welcome to attend EBGS. They are usually they're like the opposite month from here on a Thursday afternoon.
And their first week of February and April are the next 2. So they're all on our website. And also, you know, we are publishing all these meeting materials 6 weeks in advance, and welcome you, colleagues, to be sending us public comments and feedback early and often, because that helps it be better.
And has already made changes. I've had some input from members and
Great.
that changed the staff recommendations.
Great.
I also wanted to mention, if I could, that the website we built is searchable and sortable by meeting date and by the date by which we need advanced public comment.
Yes. Thanks to Daphne for pulling that together so quickly.
Is it searchable by topic?
Yes.
The key topics, yes.
Oh, great.
But it's not like fully keyworded, so
Broad.
yeah, I would start with kind of the specialty area and drill down from there. But
Yeah.
there's only like 20 entries.
Right,
and
each specialty topic has, you know, many diagnoses that are dramatically changing.
And we still continue to be in our hiring process. I don't have any news today, but I'm hoping to have some soon. And our disabilities advisory panel that we started, we're still trying to figure out what to do with that. Again, no announcements, but still working on that. We've been meeting with some of the advocates. And I believe, Liz, was there an errata published recently?
Yes. Okay. Can you pull it up?
I think those are all the staff updates. Any questions? Go ahead. Let's just talk about this for a future meeting.
Yeah, there was an errata, there were a couple of corrections, nothing
On the
dramatic.
screen.
Oh, thank you.
All right, and
Public safety announcement, the coffee is hot.
all right. All right, with that, we can go forward with our opening presentation.
Yes, please, opening presentation.
You're not gonna mention Pinzon's reappointment?
Oh, yeah. Let me come back. Chris? And I'm sorry, I've been out of the country. I am assuming you would like to be reappointed to this committee.
Oh, yeah, I put in my application and I think I just saw the information about the appointment. And
Okay.
I'm trying to find,
And
I
that's
was,
for her.
I haven't looked at the
That's-
dates for
That's
confirmation.
with the governor's office, so
Mhm.
that is in process, but we'll also be proposing to have you reappointed to this subcommittee at the HERC meeting this afternoon. So just letting everybody know that we've got some terms, we're trying to monitor that with our new policy. Okay,
So that was a yes?
that was a yes, but we'll vote on that in the afternoon.
Got it, thank you. Thank you,
All right.
Chris.
Then just to review, as we get down to our agenda proper, OHA has a goal to eliminate health inequities by 2030. We're here to make coverage recommendations for the health plan affecting over 1 million OHP members, as well as families, caregivers, and providers. We are not making decisions about individual care. These decisions are about coverage and benefits and medical necessity for the Oregon Health Plan. We will hear some public comment later this morning. Any decisions made in this meeting from now till 1 o'clock are not final until approved by HERC, which meets at 1:30. They will be implemented at later dates. In most cases today, those will be, actually, in most cases, they'll be January 1, 2027, although the number of them will be implemented earlier, and we'll try to be conscious of mentioning that. Our general considerations include the assessment of the balance of benefits and harms based on the evidence, our best assessment of patient values and preferences, and that's expressed through public testimony as well as providers' experience of the choices patients make. We also want to keep in mind good stewardship of public resources and just the nature of the healthcare delivery system. Sometimes decisions, once implemented, don't end up looking like what we might have envisioned. So we want to be as mindful of that as we can so that the decisions can be effectively implemented. If you are attending online, members, can you ask that you please be on camera and attentive. DM Daphne, logistical issues, stepping away, departing. Members can vote in the chat or verbally, but again, we're going to do that on a roll call this time because of public meeting law. And we ask that you just speak up or raise your hand rather than using the chat. It's hard for anybody to monitor all that, and we just want to keep all the discussion transparent and open and make sure everybody has access to everyone's opinion.
So that's different than what you said earlier. So online and in the room needs to make a verbal notation.
I'm sorry,
Roll.
you can vote in the chat
You can
Okay.
say aye or nay in
and
the
we'll
chat.
announce it verbally.
Yes.
Okay, thank you.
But as for comments, if you have something to say, please don't just raise your hand or put something in the chat because we might not see it or not all the members might see it, and we want to make sure everybody.
So all comments should be verbal.
Yeah, comments should be verbal.
Thank you.
Unless it's just logistical to Daphne. that you-
Correct.
You have to take a bio break.
Right, and we will try to make time for those. And then other participants, if you're just here to watch, if you have logistical questions, use the question and answer feature and Daphne or Jessica will help you. We can't get into substantive discussions in that Q&A, but if you can't hear or having some technical difficulties, please use that feature. If we can't answer it right away, we'll get back to you after the meeting.
And be aware that any comments you put in the chat are in the public record.
Correct, they are public record and could be released. Well, and everybody on the meeting could see them. The meeting will be recorded and will be posted online sometime next week. In addition, there's one thing I wanted to say. I think that's everything. Yeah, I think that's everything. Feedback, herc.info@oha.oregon.gov. That is our best way to reach our team, and we'll get it to the right person and respond as soon as we are able. So with that, let's go. I think we need to approve the minutes.
Yes, we have to approve the minutes. Has everyone had a chance to review the November minutes? Does anyone have any comments, any corrections, any other changes that you want to have discussed? Hearing none. Motion to approve. Second. Motion and second to approve.
All in favor, say aye or notate such in the chat online, please.
Aye.
Do we need to go around?
Aye.
We need to make sure we know how everybody voted.
Okay, so Katie.
Aye.
Max.
Aye.
Aye.
Joe, aye. There we go. Everybody in the room is an aye.
And do we have Sarah, Chris, Lucy,
Aye. From Chris?
Sarah?
Aye.
Oh, we said
Lucy?
aye. Oh, we all said aye in the chat. Aye.
Oh, you said aye in the chat, I'm sorry. And Mary? Anybody we missed?
Antoinette, aye.
Antoinette, thank you, Antoinette. Sorry, we can't see everybody.
Would this be easier
That's
if
okay.
I called the roll?
Yes.
I think it might be. Thank you,
Okay.
Daphne.
Yeah, I'll do it.
David Sanger.
So that's
All right.
8.
Should be-
Okay, straightforward.
Oh, and Jason, I don't have the real annotated agenda open. If you do, can you keep track of votes?
I'll do my best, yeah.
Okay.
Okay, so now straightforward consent agenda. There you go.
So we have our usual consent agenda table where there's code pairing changes. Does anyone want to pull any of those out for further discussion? Anyone online?
We're on
And
page
then-
61 of the packet.
Thank you. And then the other consent agenda item is some guideline note changes. We're deleting some guidelines that as we're going through the unfunded area of the list, we're finding that they're actually not needed. And there's adding some codes to certain entries and guidelines. The American Academy of Pediatrics has set out a new practice guideline for physicians, pediatricians, family docs to do silver dining fluoride in the office. We have a guideline about that with only dental codes. So the proposal is to add the medical codes. And then again, sort of just adding codes. One additional item, we talked about hypoglossal nerve stimulation at HERC in October, and we're updating the data blast review in guideline, in excluded guideline 2. Any questions about any of those changes? That is the consent agenda.
Shall we vote on that now? All right, so I'll entertain a motion to approve.
Moved.
Thank you. It goes Lucy.
Yes, second.
Lucy moved. Adrian, want a second?
Antoinette,
Approved, A.
Mary Engrave,
Okay. Approve.
She voted
Holly
yes.
Jo Hodges,
Yes.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
Lucy Langer,
Yes.
Sarah Love,
Yes.
Chris Pinzon,
Yes.
and Catherine Shable.
Yes.
Thank you.
Moving on to our,
We need to do conflict of interest disclosures.
Oh, thank you. Are there any, yes, we need to ask that. This is a new practice and we need to get that on our annotated agenda. Does anyone have a conflict of interest to declare with respect to any item on today's agenda? Hearing none. Let's go ahead.
the
All right,
first
new discussion
topic
items.
in our discussion is hyperkinetic biliary dyskinesia. The first item on our new topics is hyperkinetic biliary dyskinesia. This is a
Page
condition
70.
where the gallbladder contracts and empties too quickly, kind of like a big cramp of the gallbladder. It causes pain and cramping in the right upper quadrant. One treatment is cholecystectomy or removal of the gallbladder. We have a guideline for cholecystectomy for cholecystitis, which is an infection of the gallbladder, and biliary colic, which is recurrent pain related to gallstones. We have in there about hypokinesia, so a gallbladder that doesn't work well and doesn't eject. So this would be kind of the other end of the spectrum, a gallbladder that works too well. There was a review in 2024 of biliary dyskinesia, basically noting limited data available as it's kind of an emerging area of the literature. Mostly retrospective case series, which is what you generally find in the surgical literature. And they essentially cited 4 different retrospective cohort studies that found some improvement in symptoms in those groups. There was a comparison study in 2021 by Williford et al. Looking at cholecystectomy or operative management versus non-operative approaches. There were 68 patients, 18 underwent cholecystectomy, the vast majority reported their symptoms were no longer present. 50 patients had prescriptions, diet modifications, etc. And the conclusion was the patients with surgery reported improvement in symptoms, while patients managed non-operatively did not report significant improvement in symptoms. Then there was a retrospective cohort study in 2021 of 91 patients that found about 90% resolution of symptoms after cholecystectomy. Another retrospective cohort in 2024 of 57 patients found about 93% resolution, and then they did find that some actually on pathology had gallstones and other issues. And then another retrospective cohort study in 2022 of 48 patients found 95% resolution of symptoms with surgery. So we have never had looked at this prior. There was no submitted literature. We did not consult experts. In summary, cholecystectomy for hyperkinetic biliary dyskinesia, it's been studied in small retrospective cohort studies, but these studies consistently show improvement in symptoms in the vast majority of patients undergoing surgery. This is a known limitation in the surgical literature that you typically do get retrospective cohorts. It's unusual to get sort of a randomized controlled trial. The best would be that we usually see is the one that I mentioned, where they have a control group that's non-operative management versus an operative management. It does, because there is in the limited literature a signal of improvement, the HERC staff recommendation is to modify the cholecystectomy guideline to allow gallbladder removal for hyperkinetic or overactive, as well as hypo or underactive gallbladder. And that would simply be a modification of guideline note 167 when it talks about ejection fraction less than 35%, which is the hypoactive, or hyperactive with ejection fraction greater than 80% on a HIDA study.
So is that saying just if their HIDA is over 80, they don't have to have any symptoms that we can cover it? Because that's how I read it, both for hypo and hyper.
That is how it is literally written. We could add wording about.
Yeah, we're just wondering if A shouldn't become like just part of one or whatever, and then. So you have to have these.
Yeah, I looked at this.
In addition to one of the following.
I looked at it before we were looking at it, and I was using 80 and the Rome criteria for functional gallbladder disorder, just essentially biliary pain, because that's what kind of a bigger study looked at. So it makes sense to me to have symptoms associated with that finding.
Okay, so I'm sorry, how would you propose editing this?
I mean, it really would just probably be fine just to have A1 with a hyper.
A1, so
Yeah.
presence of right upper quadrant, abdominal pain, mass tenderness, or positive Murphy sign?
Okay, but you know what, look at the way it's written. Max, look at the way it's written now that I'm actually looking at.
Yeah.
So it says number one and two
Yeah, I mean,
or
without the
three,
and.
so it already says that. So you already have to have one.
Oh, I see, okay.
Yeah.
So we could put
You already have
gallbladder
to have
ejection fraction of
one.
less than 35%
Or-
or more than 80%.
And then so just so that gallbladder ejection fraction of 35%, or it could be, but do you see that, does that make sense now? It already says you have to have number one.
I feel like the way it's
A1.
written, it's like it's either 1 and 2 or 3. Somebody could read it that way.
So
With
I read it, you
because
need
A says
A,
with
B,
either.
or if you're Billy.
See this right here? And. So
What-
you have
See
to
this right
have
here,
one.
with either 1 and 2 or 3.
Right, but if you read the last,
One,
if you read the last part, it doesn't say anything about needing A or B.
Which last part?
So we could actually, to
For
clarify,
the
we
very
could say
bottom.
with either
No, the very
1
bottom.
and 2
For
or
diagnosis.
1 and 3. I think that's what we intended.
So you.
How about
Just add
and
one into
either?
A, that one statement should just be part of A, and then you can have.
Yeah, there you go.
This, it.
So what I like Jason's edit, so at the end of 1.
Yeah, so
Oh, I see.
move the either to after the and, Liz.
So I don't have any problem with the wording of A or B. To me, it's not clear that you need A or B with
Okay,
the height over 80.
so now it's A and either 1 or 2, and we can add this onto 2, right?
So how I have it written is A, for cholecystitis with the presence of right upper quadrant abdominal pain, mass tenderness, or positive Murphy sign, and either one, evidence of inflammation, blah, 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 or ultrasound findings, blah, 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 or, and in there is gallbladder ejection fraction of less than 35% or greater than 80%.
Yeah, it should be greater than it, yeah, there, yeah,
Mhm.
yep,
And then we'll also include the staff wording at the bottom.
sure.
So we're taking it as Ariel read it, not as displayed on the screen?
Wait, what, I'm like,
That was
I
my-
love it as Ariel.
You have it the same, okay. I must have lost my phone. Still jet lag.
Keep up.
Fourth grader.
Yep, and then we have, and the either is new as well, and then there's a little bit of wording. We mushed some words together to take away the one to make it part of it.
Do you, what about?
And I think we need to keep that.
Keep that.
So that stays down there because what's the purpose when the patient can, of course.
It's using the code, what that code
Other
means.
specified disease of gallbladder.
Yeah,
is included
there's no specific code.
When the patient has this. Okay, so, but, is this where we need it to say and meets above criteria?
Yeah,
So I think the other,
Okay, after 80%.
right, because then otherwise it looks like
and
that's all you have.
meets
that's why I'm getting
above
confused.
criteria.
There we go, got it. Max, you're not as crazy as you thought you were.
I think I was.
No, I think you've just improved this. Now we have to go back through when we talk about this.
Had to
We're
figure out-
gonna have to re-edit the guidelines.
I had to figure out myself before we talked about it here.
But what we
That was the
intended,
only
we've
problem.
always intended, you obviously need to be symptomatic. If you just,
Right,
they do a height scan and you're like, I'm fine.
Well, and that's,
Like,
so-
I've had a lot.
sorry though, because.
so backing into it, I was like,
Yes.
well, nobody's gonna get a
Yes.
height scan
I've
unless
had a
they
lot
have
of
symptoms.
symptoms.
I've had a lot of amorphous symptoms with IDA, and because they can't figure it out, but through a lot of other testing, that's. So there's one, sure.
Okay.
And even the Rome criteria is actually a little more specific than that, because it talks about the growing pain of food and decreasing all that, so. It's mostly, in line with what it says.
Are you okay with this one?
I think it should be equitable for hypo and hyper. They should. kind
It
of
should be
the
like,
same.
Speak
The
up.
hypo and hyper should be the same, it kind of makes sense.
Okay.
I don't think it should be more restrictive on one versus the other, because as far as I know, the
At
data's
two
kind
ends
of
of
similar.
abnormal spectrum, maybe.
As far as my,
Okay,
yeah, I
maybe.
haven't dove into the hypo, but that's kind of my understanding is.
It's the same evidence.
Right.
Base.
Right.
Ish.
So I think we should have the requirements for that, the same.
All right, I think we have improved our guideline.
I do too. Excellent, did we vote? We move on.
What do we have for new discussion?
Acute dermal matrix is next.
Should we vote on them all three at once?
You can choose to do that, go on the block.
Okay, let's vote on this block. So let's talk about dermal cellular.
Okay, so acellular dermal matrix for breast reconstruction. So when a person has,
Page 74.
thank you, when a person has a mastectomy, generally for cancer, it may be for other reasons, and they desire to have a reconstruction, so sort of an artificial breast created, there's different ways you can do this. One of the most common ways is they use some type of a acellular dermal mesh, which is this product. It can be made from human tissue, animal tissue, or it can be synthetic. Typically, it's meant to dissolve, so it kind of supports the tissue while there's healing. And then the surgeon, the implant or whatever the surgeon is doing to create a new breast would then be healed in. There is one code, CPT 15777. We have had this on our guideline note 173, which is now excluded guideline 2, because there is significant concern about acellular dermal matrix of a human origin. The FDA actually issued a safety warning about human acellular dermal matrix in 2021 because of safety concerns. However, unfortunately, we've discovered in dealing with the breast surgeons helping us review all the things for BUP, that there is no other code for the non-human or the mesh or anything, that the surgeons have to use this code. They are aware of the safety issues with human, they're aware of the FDA warnings, they use various, they use what they feel is most appropriate for the patient. So the evidence review in here is essentially looking specifically at the human base, and it continues to show significant concerns with increased infection, increased wound dehiscence, things like that. The breast surgeons offered their own literature about how using some type of acellular dermal matrix will frequently allow them to do a one-stage reconstruction instead of a two-stage reconstruction. The American Society for Plastic Surgery noted the FDA safety warning and determined that the type of product used and what to use, how to use it is a shared decision between the surgeon and the patient. Every private insurance I found covers acellular dermal matrix for breast reconstruction. Their guidelines were typically lists of the products they do and don't cover. This group typically doesn't deal with that granular. We just deal with the overall. There may be at the CCO or at Medicaid level, there may be some, because it's kind of a product, there may be rules and things, but we don't get into that kind of detail. As I mentioned, I have had conversations with several breast surgeons who are pretty passionate about the fact that we don't cover this. So essentially, the evidence is still bad about human acellular dermal matrix. However, all the other types of things that the surgeons are using unfortunately use the same code, which staff did not realize. So now we realize that we need to cover this code. Staff talked to the CCO medical directors to see if they would prefer a guideline saying no human. And they said that it would, at that point, it's too hard for the review and they preferred no guideline. So the staff recommendation is to add this code to the breast cancer line and the gender affirming treatment lines, and then remove it from excluded guideline 2. Questions, concerns, input?
This is Chris. I'm wanting to understand. So there's no way to differentiate because there's only one procedure code, that 15777. And
Correct.
basically it's a major tool in their toolbox that,
Yes.
and we can't differentiate between all those tools. And we're leaving it up to their clinical judgment and the conversations with individual patients to find the best risk-benefit solution for each person.
That's a wonderful summary.
Okay, would support that, yeah.
And I'll just say, Mary, you're probably gonna say what, you wanna say something, Mary?
Yeah, that was a great summary and actually a great follow-up question. I was gonna say I completely agree. And we've looked into this quite a bit, talked to a number of surgeons about it when it first came up. And I think there is no way we can delve that deep. It's kind of like if a hip implant has been recalled, the surgeon's 99.999% of the time are gonna know that, but we're not gonna deny hips, right? Like, so it's kind of the same thing, but great summary and completely agree with this recommendation.
Thank you, Mary. And I'll say, some of us have already been approving this for breast surgery only. Already. Because it really, it interferes with their ability to do their work. Lucy, you look like you wanna say something.
Okay, great.
Okay, I'd entertain a motion to
There's
approve.
one more new discussion item if you want to go.
Oh, okay, we're gonna have, sorry, one more.
This is screening breast MRI for high-risk patients. You're seeing a theme here. I talk to breast surgeons.
Age 85.
Most breast cancer screening just needs mammography. There are a certain group of people who have extremely high risk of breast cancer, perhaps a BRCA known mutation or other reason, where the guidelines would recommend MRI alternating with mammograms. We have a guideline that allows breast MRI with in a whole series of reasons. That guideline is not in alignment with current NCCN guidelines, which is where we initially took we wrote the guideline based on the NCCN guidelines. The breast surgeons pointed out that they're no longer in compliance. So we rewrote the guideline and the breast surgeons are happy with the modifications. The main modification is that high risk, so we had basically gotten into like nitty-gritty detail about what's a high-risk genetic mutation, and things have just blown wide open. There are many, 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 many other genes identified, et cetera, et cetera. So we are basically saying it has to be high risk according to NCCN, and we have to mention the specific version of NCCN. The other thing that NCCN has added is atypical ductal hyperplasia or lobular neoplasia, because these are higher risk lesions compared to like a standard DCIS.
Do we have to list the specific NCCN guideline we're linking it to, or can they link it to the most recent NCCN guideline and let it change?
Not for
further?
appeals and things like that.
We have discussed this before. It would be lovely to just say the most current, but legalese, we have to have 8 documents. And that means I have them on a list and I have them on a list to update once a year.
Yeah, okay.
Great. Sorry.
Yeah, the frustrating part is generally when you, the updated ones usually have, you know, an increased and expanded coverage for things, so if you do use them, you don't get in trouble, it's when you restrict things more than what they are, so I think in practice, when a new guideline comes out, most of us use it.
Yeah.
If it updates before the once a year, because again, it's generally expanding coverage.
Old one disappears this.
And it's
Yeah,
hard to find.
the old
it.
one
Impossible to
disappears.
find.
I can't find it.
I apologize. It's not my role. If I
I
was
know.
queen,
Exactly.
No, I don't, we've gone through
Yeah,
it.
no, we.
That's why we use the
sorry.
new one too,
Yeah,
the
we
old
do
one
it.
literally.
Goes
is
away.
next.
and I just wanted to note for the record that Antoinette Aoyaki has joined us in the room. Welcome.
Good morning.
All right, so that is the new agenda items. Do you want to entertain a vote on the?
So yeah, let's take those 3 agenda items and need a motion to approve.
Motion to approve.
Katie? Okay, Katie, and then seconded by Chris, and then everybody in favor, please go ahead and call the roll there and we'll announce.
Antoinette,
Yes.
did Brian Duty arrive?
Not yet.
Not yet.
Okay, Mary Engrove,
Okay.
Holly Jo
Yes, that was
Hodges,
approved.
Yes.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
Lucy Langer,
Approved.
Sarah Love,
Yes.
Chris Pinzon,
Yes.
and Katie Shable.
Yes.
Thank you, everyone.
Approved as modified.
Approved as modified, yes. And that was just the one modification to the 2 were.
Yeah.
So we have one biennial review item today. We have one line below the funding line for a couple of types of liver issues or liver transplant. These diagnoses are above the line for other types of treatments. We have previously discussed with liver surgeons that neither of these conditions is actually an indication for liver transplant. And so the suggestion is to simply strike through that current line, and then effective January 2026, the line will be deleted. These codes will not pair with transplant, and they will pair with all the other appropriate treatments as they do now. Questions, concerns?
This is Chris. Does that help clean it up?
Yes.
Yes.
I'm trying to delete lines that are not functional below the funding line so that we don't have to deal with them in the bulk process. So you'll see a few
Yeah.
more.
Thank you.
I guess we'll need to entertain a motion to approve as written.
So moved.
Thank you, Lucy. Second,
Second, Meredith, second.
there we go. Mary seconded. All in favor, we have to do this every time?
Yes, sorry.
Sorry, okay, quickly as we can.
Antoinette?
Daphne, go.
Yes.
Mary Engrove, Holly Jo Hodges,
Yes.
Adrian Irwin,
Approved.
Max Kaiser, Lucy Langer,
Yes.
Approved.
Sarah Love,
Yes.
Chris Pinzon,
Yes.
Katie Shable.
Yes.
Perfect.
Motion
You guys
approved.
you're just streaking through. We are up at the benefit updates project. We have a short presentation before we start, I wanna like, everyone take a deep breath. If you look at the agenda, there is no way we're getting through all of the BUP items unless you guys are just like on super kill coffee this morning and you're doing great, in which case staff is delighted. So we can do it. I have found when I've worked with different specialists that the first few of these go really slowly and then they speed up as people kind of get used to what we're doing and kind of mind shift. So don't be frustrated if it takes a little while. What staff is asking of this group is either, yes, this proposal makes sense, we agree with the staff recommendation, it should go to HERC and get approved, or I have a question about this, I don't agree with you about this. If it's just a quick question, we can discuss it and then approve, great. If there's anything in depth, what staff will do is we will just get all of the questions and all of the concerns raised and then table it, and it will come back to another meeting. Does that make sense? So we're not gonna go into like really great in-depth discussions on any of these. You will also notice that the summaries look a little different than the summaries you've been seeing before. I took your feedback from our November meeting when we had kind of a test one about allergies. So at the beginning, there is a list of things I think will be somewhat controversial or need discussion. The first, I've tried to kind of start with the easier ones, so most of those really aren't a change. They're just a lot of technical changes. But when there are questions or things, either I don't agree with the specialists I talk to, there's something that might add cost, there's something that's of high interest to the public, something, whatever, so you will see a different format. Please give me feedback on the format. If you actually like this format better, we may switch all future things that come to you to this format, or we may continue kind of the regular things getting a little bit more. There is no in-depth evidence review. Unless I have been contacted ahead of time, like I did with one HERC member about a question, there you will see more of an evidence review there. So it's a very superficial look. So it's gonna be a bit different than what we normally see. And we'll kind of walk you through it. Like I said, it's a bit of a mind shift, so just give this whole group grace while we sort of start in on this.
And if I may, and if there's something that is not called out for discussion, we should have missed it, please speak up.
Oh, of course, yeah,
Yeah.
it's the things that I personally think, and we also, Marcus Bachhuber, who is one of Val's colleagues who works at the Center for Evidence-Based Policy, he's an internist. He has been re-reviewing to get a second clinical opinion, unless I have expert specialists that I've been talking to. So there's at least 2 clinical inputs on everything, but that's why you all are here. You're another set of eyes and another brain, so definitely bring any concerns up, and everything's on the table. Any concerns you have are on the table. The plan is to get all of the materials out probably by the April EBGS meeting. So you guys will do this, EBGS will do it in February, you'll do it again in March, EBGS will do it in April. There's no way we're getting through all of the things, but it should be in the world to get people to look at it and give me comments. Our task is to get through everything by the November meeting, and I'm hoping October, because November is usually a really busy meeting with codes. So that just gives you kind of a cadence of how we're doing things. And what I'm planning on doing is hopefully we'll get through everything in October with maybe a few little ends in November. We'll bring you a package of what it looks like. And be aware that things have evolved, even like, so you might see some things today and some of the categories may actually have a slightly different name later, and it's because it's evolved, and we're gonna try to like sort all that out. So you'll see a final package. We want that done by the end of the year so that it has a year with the actuaries and with the CCOs and with everybody to digest it, price it, etc.
All right, and now we have as you may recall from the last meeting, we talked about how our decisions will need to align with the OHP definitions of medical necessity and medical appropriateness. I think the values are very consistent with what you all have done for years and years and years. But just to review that, just to kind of put everybody in this new mindset, Marcus Buckhoover again helped us develop this presentation. I'll just review it briefly and then we can dive in. So medical necessity is a concept that's universally used in healthcare in the US. It is used but not defined in federal law. Medicaid can only pay for, scare quotes, medically necessary services, with each state having its own definition. For OHP, medically necessary, medical appropriate are defined in state law, and there's the OAR reference, administrative rule definitions.
And just to emphasize, we talked about this a lot in November, this is not our definition. HERC does not make a definition, it's already defined.
And so HERC developed code pairings and criteria, so now we're in 2027 land benefit update project.
And actually, this is current. This is also
And this
current.
is also very consistent with what we do. The difference is we won't have a funding line. But the code pairings and the criteria that expressed in the guidelines define essentially what is medically necessary for OHP, plus the agency rules and policies. So for example, there's quantity limits on certain durable medical equipment. HERC doesn't usually address that. We don't get into which brands of skin substitutes you use or which vendor you use for your genetic tests.
There's also state laws and policies. We are mandated to cover certain things. We are mandated to not use federal funds for certain things. So there's an overlay.
Yeah, and a lot of this has, there's a lot more complexity, but in general, we're trying to define the clinical criteria, the correct code pairings to make sure that the benefits that are medically necessary for, 95+% are pairing so that those claims can be paid efficiently. So just to review medically necessary services. So now I'm getting in, so in the national world, it's medically necessary, medical necessity. In Oregon, we kind of bifurcate that a little bit. So this is the first half of that medically necessary in Oregon terms. They include services for the prevention and early detection to prevent illness or impairment, diagnosis and treatment of acute illnesses, including emergencies, diagnosis and treatment of chronic illnesses to prevent complications, services to improve function and independence in activities of daily living, and helping children achieve age-appropriate development. And for children, there is a special definition that has some nuances, but the principles are generally encompassed there. Again, you see the administrative rule reference, and there are no plans to change this definition because of the benefit update project. Go ahead. Services that are not medically necessary. Examples include, but are not limited to, services that are ineffective, unproven, or harmful, more costly than an equally effective and readily available alternative. Experimental, investigational, cosmetic, or the term used in rule is, I think, principally for the purposes of improving appearance, which has a lot of P's in it. Solely for the preference or convenience or of the member or provider. We're not going to pay extra, so versus the red one, or things like that. So it needs to have a health purpose. The plain language Marcus came up with, I thought was really good, that we're using is for health reasons. And so that's we wanted to have a healthy impact. So go ahead, Liz. As with other states, OHP does not cover all medically necessary services. Unfortunately, there are limits on our benefits due to legislative constraint, and in some cases, it's just not our lane, it's not healthcare. Some examples are fertility services. We know that those are very important to people, but they are not part of the benefit package. Some important dental services for adults. For example, root canals, crowns, certain dentures are limited in the benefit package for adults. Drugs for sexual dysfunction, that comes from federal law. Hair growth treatments or hair loss treatments. Hair growth or hair removal. And then eyeglasses. Now, these services may be medically necessary. I'm wearing glasses right now, but they are unfortunately not in the OHP benefit package, and changing that would require action. In most cases by the legislature, in some cases might possibly be done by the agency. Here's a new graph, image also come up with Marcus. you can see there's two axes. It's kind of like a window diagram. So across the x-axis, the top, is it medically necessary? Yes or no? If yes, you can see in the top half, it's covered. In the bottom half, it's not covered because it's not in the benefits package. If it's not medically necessary, it's not going to be covered whether or not it's in the benefit package because it's not necessary for health reasons. Let's pause on that one. Any questions on that diagram or anything I've been saying in the last few minutes?
Mrs. Chris. This is Chris. Can I comment? I have, I think, 3 scenarios that I'd like to play out. The first one was about cosmetic and the hair growth treatments, because I think that's where a lot of the gray area might be. And I'm wondering how that might play out with some of the gender surgeries and just more of not the medical, but the mental components, and whether we're looking at health holistically or just simply as how are you defining health? And then the other one, I saw in that first line that it said preventative services were covered. And so I'm wondering, coming back, I know we have a challenge with vision, but would there be a place there for an initial eye exam for everyone once in their lifetime by the age 40, which is the recommendation for the AAP, versus treatment?
Right, and we cover the vision screening, particularly for children. Unfortunately, we don't cover the glasses, and that is a legislative decision.
But what about
here,
for adults covering an initial
I believe,
vision
Yes.
exam?
I'm sorry, for adults, what was the
Yeah,
last thing?
a comprehensive exam by
Yeah,
the
a
HEB.
comprehensive eye exam is a benefit. Unfortunately, people tend to be less motivated to get those if the glasses aren't gonna be covered, and it's just, this is a function of our system that we are not able to change it as a part of this. So with respect to for appearance only and cosmetic, this is a gray area. And outside the realm of gender affirming treatments, which I'll get to in a moment, it is your call. There are cases where HERC has said, for example, I believe it's for wine stains on the face or hands or certain parts of the body or covering a certain amount of the skin is medically necessary, not because it has some other health impact, but because it has an impact on how people get treated in society. There are other cases where HERC has made, drawn that line. And so that is where we're looking to you all to make that hard decision.
Yeah, I think about a lot of cancer cases too.
Right, breast reconstruction after cancer is another example.
and things like wigs, there are federal rules. You can supply a wig if you lost hair for cancer treatment, but not if you lost it for autoimmune disease. The agency could work with the feds and write, kind of add, it's a whole big process to add coverage for it. So it's that, again, I mean, if the HERC was, you could have input, but it wouldn't.
You're not the decider.
You're not the decider.
Yeah.
Yeah,
With
the
respect
federal ones.
to
That's
gender
what I was trying to think.
treatment, it is a little bit nuanced. Gender, people who are gender diverse, non-binary, trans, have goals related to their appearance as well. And there are goals related to their gender dysphoria or gender identity as well. And the law, House Bill 2002, that was passed last year, says that services cannot be denied if they are gender affirming services, according to the provider who prescribed them, because they are cosmetic. However, it also says that they cannot be denied if they are provided in accordance with accepted standards of care. And so the question is, if the service is being recommended that clearly, is not part of the accepted standards for care, it gets nuanced there. And the bill also provides that if there would be a denial, kind of in that space, it would need to be adjudicated by a provider with experience in providing gender affirming treatment. So again, this group will not get into that space because that is defined by statute. Does that?
Okay, so there's no, yeah, I was just trying to figure out how to make that easier to implement, whether it would be a carve out or whether if we work out that
Yeah,
except,
it's just,
sounds like
it's
it's
just
not
something.
in our purview.
No, not at all.
Yeah,
Okay.
those are highly individualized and we cannot deal with that. We're dealing with, there's a state law that would supersede anything we did, and B, you know, it is highly individualized and nuanced, and that's why there are individual reviews. But outside of gender affirming treatment, you know, that is a space where this group should be discussing, you know, as we did with acne, as we did with psoriasis, like, where is that line? Where it's principally for appearance versus for health reasons.
Antoinette, you had your hand up.
Yeah, just to close it out, because I know this is not the area, Jason, right on, because I work on the rulemaking, with the Division of Financial Regulation. And, the accepted standard of care at a minimum is those prescribed by WPATH. Again, at a minimum. So it's like you start with WPATH, which they are really not evidence-based. You're more like a advocacy, you know, group. So we're required to start with that at a minimum, in making coverage decisions. So, I know this is not a purview, but I wanted to add what you said, and you summarized it really well, Jason. Good job.
Yeah, thank you. All right, so we're gonna be patient and we're going to work through this, but we also have a lot of material to cover, so. So please raise your hand, speak up if you have questions, quick ones that we can work through, and otherwise we're gonna have Ariel take them back and work through them and then bring them back at a different meetings, so buckle up, here we go.
But I
Are you
wanna.
going to proceed with your presentation, or are you done?
I thought you were
Oh,
done.
do we have
These
no
are my
slides?
slides,
Yes.
I have a couple slides.
Okay.
So
Sorry.
basically,
Old time.
basically, what I wanted to kind of do is tell you, like, the more things change, the more they stay the same. We use certain words in HERC, like code pairings or above and below the line. We're gonna need to change our words. We are still gonna have code pairings, they're just gonna be called like a code pairing group. They're not gonna be a line anymore, but it's essentially a line. So currently, under what we currently do today with the prioritized list and OHP, if a claim comes in and it's for a gallbladder removal for cholecystitis, the diagnosis code, the procedure code pair, the computer pays the provider. They want to do a cholecystectomy for a brain tumor, the codes don't pair, a nurse may review it to see if it's something unusual, and then it would deny. So currently, we have code pairings, certain codes and certain lines pair. There's an extra thing of above and below the line, which, and then we also have guideline notes. So you get, like we just talked about the cholecystectomy guideline. So we do cholecystectomy, but only if you meet certain criteria. So those things are essentially gonna stay the same. They just are gonna be different terms, if that makes sense. So code pairings will still determine whether, like, you will not be able to get your gallbladder out for a brain tumor going forward, but you will be able to continue to get it out for an infection of the gallbladder. So currently in depression, you could have psychotherapy if that is what you and your provider decide is needed for you. But you couldn't get psychotherapy for a stub toe. You can get an IND to drain an abscess. So the code pairings, if they're paired correctly, we never even see them, they get paid by the computer, however that happens. Guideline notes are the detail. What you are doing right now is you're doing these code pairings and these guideline notes. And again, there's all these like rules and policies and state laws and things that are overlay on top. Next slide.
Brian Duty's here. Brian Duty is.
Oh,
here.
hello.
Oh, welcome, Brad.
Welcome, Brian, thank you for joining.
Yes,
So,
I'm not there in person.
and then in the current reality, the prioritized list, we currently actually, so things are called unfunded or below the line, we actually already pay a lot. We already cover a lot. So if a child has a diaper rash and their parent takes them into their pediatrician or family doctor, that office visit's paid for. The nystatin cream, which is the diaper cream, is paid for because it's super cheap and nobody PAs it and nobody cares. The patient just picks it up from the pharmacy. So essentially, we are actually covering the diagnosis and the treatment. So it's a little bit of a fallacy that things below the line are just not covered at all. The same thing with a cold. Colds are below the line. You go to your doctor because you think you have pneumonia. They do an exam, they might do an x-ray. You don't have pneumonia. You might get a decongestant or whatever, and that would be paid for as well. So the tests, the visit, meds that don't have a lot of safety risk or cost or other reason to PA are going through. So a lot of what is currently called non-covered is actually covered. A lot of what we're going to be doing with the BUP process is making that more obvious. So kind of shifting our mindset, but again, it's just continuing what we're currently doing for many things.
It's making it more obvious that it gets covered.
Right, exactly.
Because of just like the practical way these things happen.
Exactly.
Instead of having listed as uncovered, because that's unpopular.
Yeah, so next slide, you'll see the new reality. Again, so currently funded stuff will continue to be covered the way it is. Currently unfunded will again be covered for the office visits, the diagnostic tests, and the medications if they meet all the pharmacy criteria, so no change. There might be some more DME if they meet the DME rules, and then there are ancillary services like anesthesia. So we eventually we're gonna have to talk about ear tubes for chronic otitis media. If we decide to cover that, we will cover the anesthesia that is required.
Yeah, so in that space, if there is DME or other ancillary, although probably mostly DME, that is commonly prescribed that you believe is not medically necessary, that's something we can highlight, put a guideline, like we have for continuous glucose monitors, for example. Usually that's just gonna be covered when medically necessary according to, each CCO's criteria. But if you'll want to have a guideline in that kind of scenario, that's a place we can work. But for medications, that's done by the Pharmacy and Therapeutics Committee for fee for service and then for each CCO.
Through the BUP process, we are assuredly going to be adding some new services for things that are currently uncovered. Many of these are already being paid through either the exceptions process, the comorbidity rule. So the word comorbidity rule is going away because that's unique to us because of the prioritized list. But you'll still have the exceptions process. So you want psychotherapy for your stubbed toe. Well, actually the stubbed toe is causing them to not be able to do their yoga that they always do for their mental health. So, it's kind of a strange, essentially we're already paying for a lot of things that are below the line. One of the things that came up recently is people who have like stool leakage, who are incontinent and are also getting decubitus ulcers. We don't pay for the colectomy, but if they're getting decubitus ulcers, a comorbidity rule, they would get that. So we're just gonna make it more obvious. And we may end up writing the kind of the comorbid stuff into a guideline. We may just decide it's not really subject to overutilization. We don't want to do anything. There's always EPSPT, which is the special review for children up to the age of 21, as well as youth with special healthcare needs. So for a service that we say is not medically necessary for a child, there is an extra layer of review that will need to be done. It's denied and the patient or provider asks for review. Any questions about kind of the new paradigm?
Ariel, this is Chris. I'm just wondering for the, where would procedure codes fall? Because it's separate from ancillary services. Like I also see, like a lot of nursing services get billed as ancillary services. But I'm wondering about some of the procedure codes, like for DOs who might do manipulations.
Right, those will be just like they are now. Now they are paired on a line. They will be paired in what we're calling code groupings. So, chiropractic manipulation for cervicogenic headache. That was one example that was in your reading materials. That would be in a group for things that could benefit from chiropractic osteopathic manipulation. Or we might just, there's there's various ways and just groupings, but that will still be how we define things. So if you have an infection in your gallbladder, it will be in the code grouping that pairs with removal of the gallbladder.
Just like it's in that line today.
Instead of a line, it'll be a code grouping, but it's essentially the same thing. You'll see fewer of them because I'm trying to condense things down so that we don't have reasons to take out your gallbladder on 18 lines. It'll be in one place, which I think will be easier for both patients and providers to kind of get a sense.
Some of you may remember when I did orientation with you, I said there's one prioritized list in the world, and we do a lot of complicated things we're basically uncomplicating that. A lot of this is just stripping it down, a lot of those artifacts of the funding line, and just saying what's covered and what's not.
And
It's a lot less change than meets the eye in one way. Those DME services, and then the things that were in the unfunded region that are procedures, those are the things we need to focus on.
And
Everything
we still
else
may
is
not,
just moving things around.
if we feel that a procedure looking at your gallbladder is not appropriate for a brain tumor, they will not be paired. So, not medically necessary, basically. If we feel that a service is only medically necessary in like never medically necessary, we're gonna have a not medically necessary group. So like reviewing the list with specialists, we would run across things that they'd be like, we haven't done that since 1950, or whatever. Or they don't even know what the actual code even represents. So there'll be things that will be called not medically necessary. We realize this isn't perfect. There'll probably need to be some changes the first year or 2 or 5 that it's out there, but we'll do our best.
And so then for the ancillary services part, this is more, I'm thinking more about patient-centered medical home and their interdisciplinary team model where we have multiple different disciplines that are all kind of, historically, they've been built like under the provider because this model is really driven by a medical provider. But now we have nursing services, we have behavioral health, we have community health workers, and those to me have all been under ancillary services. So is that going to just fall under the office visit, or how do you see those?
So ancillary services would be covered as long as they are medically appropriate. So if you have a nurse who comes to your home to do wound care and you have a wound, that would continue to be covered. I think there may even be a code for that nurse visit.
I think she's talking about APMs, alternative payment methods, and none of that stuff's gonna change. So the stuff we're focusing on is procedures below the line and DME for conditions that are now unfunded. Everything else is really gonna be status quo by another name.
Okay. DME and procedure codes.
What I have found most helpful is just to jump in and do a couple of these. It'll become more clear. So the very first one is the biggest one, the biggest group. And what we're calling, oh my goodness, so the name's already changed. So it's called office visit and medical evaluation only, and now we're actually calling it evaluation and medical management only.
Yeah.
Sorry, it's gone through many iterations, but essentially, this would be one of our medical lines now. It's got all of the 99213, 99214 office visit codes. It's got all of the HIC-PIC codes that are like for FQHC care. So it's basically anything in this group you can see your doctor, you can get diagnostic tests. If it's appropriate, you could get a splint or a bandage or other DME. It's essentially
Page 96.
changes. And there are a few things that will no longer pair. I called those out. None of them seemed to be anything essential. When I have been doing this, when I do find something that needs a treatment, I take it individually by code out of this group and put it into another. The current lines at this point, staff doesn't have the capacity to review the covered lines in detail, so they're just gonna turn into like line 66 will be code group 66. In most cases, you'll see, there's some where I am condensing things down where they don't make sense now. Max, you look confused.
No, I have questions.
Okay.
If I don't, yeah.
Okay, so essentially, so how I have structured this now is that minimal expected impact, there's a few things just to let you know. There's some things that are below the funding line that are currently covered paired with various services that aren't being paid for because they're below the line and they're not necessary, so we're just gonna unpair them. But that we don't think will have any real impact on changing coverage. And then everything else was just really paired with office visits, so it will be status quo. You'll see issues not related, and for this one, there's tension headache and cervicogenic headache, and the reason is that we ended up having to do a more in-depth evidence review, so those got pulled out, even though their line is in this group. Some of this is just because staff have to have some sort of structure. I'm breaking things down by line, but that doesn't, as you are well aware, lines can be really mishmashes, so there's some things that may be pulled out. So this group, this evaluation of medical management, so office visits, appropriate medications, et cetera, will be 30 or so lines, so that you can see here. These are things like canker sores, viral infections, things that we have some dump lines at the end where we have like no treatment necessary. There are really bizarre, really weird, rare things down there. So again, you will be able to come and see your provider, get a diagnosis, get education in the office about whatever it is, how to treat it. So what we would need to do to go forward with the staff recommendations is to create a new group, evaluation and medical management only. And then there will be some guideline note changes that will need to be done because, for example, viral infections, there are reasons you need to be in the hospital. You're dehydrated or you are super sick with a virus. If you meet hospital admission criteria, you were admitted. We don't need this guideline anymore. So acute viral infections, if they meet hospital admission criteria, you'll be admitted. So we can just get rid of this workaround. And then there is a sclerotherapy of fluid collections. We just have that in there to say that it's only necessary for bleeding, infection, severe pain, and organ dysfunction. Then if you are interested, I'm not planning on going through these big tables at the end with you, but this is the nitty gritty details that are gonna need to go to our computer systems to be dealt with. And as you can see, there are pages and pages and pages and pages of diagnoses that will no longer be, that will be in this group. This group is really important to form because this is the basis for everything else. A ton of things are gonna be added to this group as we go forward looking at other lines. Does anyone have any concerns about this as like the core group now? And probably we'll take a bunch of funded lines and dump them into this too that only have medical management. I see nodding.
Ask.
I just want to make sure I'm doing this. Okay, so as we were processing this and I'm looking through all of this, so this is a very hodgepodgey list of stuff. And so originally, I thought where this was going was that this is going to be a bucket for conditions that we were just going to provide, like that office visit, like.
That's exactly it.
Okay, so is that the final lens of this bucket? Because then at the very end, you commented this is going to be a bigger bucket that like more.
No, that's the only focus of the bucket.
Okay.
What I'm meaning by bigger is the procedure codes will stay the same, office visit.
Okay.
But more and more and more diagnoses would be put into this.
Okay, but for something that would have been like heart attack that was clearly funded, that's got all sorts of other things
Will not
attached
be
to
put in
it,
this
will
bucket.
not go into this.
But right now,
But when we find other things that we
Right.
want to put in, it'll slot in, but the intention for this bucket will stay at those conditions, kind of regardless of disease process or whatever, where the intention will be kind of like just the office visit management, like no specialist, no procedures, no.
Well,
So the-
actually,
the-
specialists will be included because they now use the same office visit codes.
Okay.
So you have a person who, your primary care doctor is not sure if you have something serious or something really not serious. Send you to a consultant, so that's paid for as well.
Maybe back up like with the diaper rash, so if like a primary care physician
Wanted to
wanted
send
to
to a
say, okay, I think
dermatologist?
you need to see a dermatologist.
But the
If- and if the
CCO
dermatologist
could
is
say,
like,
is
"This
that
is
really
funny,
medically
I wanna-"
necessary?
Yeah, and so
EPA is.
right now, probably they're just flying through and seeing a dermatologist once, but if they were seeing a dermatologist every month and coding diaper rash, that might get flagged by the CCO, and the
So-
CCO might be like, really? Like,
But our primary task here is, so for example, those codes with disorders of bilirubin metabolism. If there were an important condition there and there were a surgery for that code or any one of the ones on this list, that's the kind of thing we need to know about now. So as soon as possible, so that we can make sure those pair, because as it stands, those procedure or chiropractic manipulation or whatever.
we think there's
Um,
nothing that you need for these besides an
Besides the basics.
evaluation, maybe a specialty consult, medications if you meet, you know, whatever criteria, or if it's cheap and safe, fine, whatever. So this is like the core group. A lot of things will be added to this because there's a lot of stuff below the line that really doesn't need treatment. If and when I get around to looking at the above the line, for example, I don't know what's up there, but acne, or there's acne surgeries, maybe psoriasis. If you don't need a surgery for it, all you might need a MAB medication infusion, fine, paid for. You might need topical, whatever. So some things that we currently covered may end up being folded into this as well. That's what I meant by.
And you can pause there, Liz. So for example, J 92.0 pleural plaque with presence of asbestos, there's a note over there that says it'll no longer pair with all those procedures. If we got that wrong and something there is important, again, that's the kind of thing we want to be calling out here.
Yeah, and if there was a procedure, you're like, oh, wait a minute, we always do. We take out the whole lung in that case. Then flag it for staff. Staff will talk to a specialist or do some research. Yes, that is what's really being done. And we'll make sure it gets paired with whatever appropriate procedure. And bring that back to you.
So these are talking about outpatient services.
Yeah, April, this is Chris. I'm trying to get my.
Just a second, sorry, hang on, we got, Max is talking here in the room, and then we'll get to you. Thank you.
So these are related to outpatient, essentially services, procedures.
Right, to be inpatient
Right.
with an illness, you have to meet admission
Right.
criteria. So you could have any disease, and if it's severe enough that you need to be admitted,
Right, there's a
that is a
couple of these.
DRG, it's a totally different process, it's.
Yeah, people have, there's like hypotension, that's common admission diagnosis, right? So, okay. I think I have some specific questions, but first let's.
Right, and people get admitted for hypotension and we discover it's because they had an MI or because they are overdosing on themselves on their med. And they usually leave with a more specific diagnosis.
Yeah, once we get one, yeah.
Okay, Chris.
Thank you, Max. I think we were going to the same place because I was thinking ambulatory versus hospitalization, and we're just trying to like move away from having to line item out every ICD-10 code and just be able to say it's an ambulatory service for an office visit. So almost everything is going to fall into that bucket. But then where it goes from there is the next piece. And I think that's what you meant by like the backbone, April. Does
Yeah.
that feel like
Yeah, and emergency department visits will also be covered because people do not know what they have.
yeah.
They feel they're having a heart attack, they're actually having a little bit of gastritis. They will get the emergency department covered at however we currently do that. If they need to be admitted for observation overnight, they will be admitted for observation overnight if they need. That gets into stuff that's way out of our rules. You know, when you qualify for an inpatient admission, and then it becomes a DRG, and then it's all sorts of stuff.
Okay, but I think I get how it will significantly simplify our life if we can do ambulatory versus hospitalization and
Right.
move away from the line itemed ICD-10
Yes.
codes that is
Yes, it
expensive.
doesn't matter how important, if you have a cold versus like a pneumonia, as long as there's no treatment other than an office visit, medications, hospitalization if needed, it will be in this group. So
Yeah.
really important things that could kill you, really minor things, things that are annoying, things you don't know, they'll all be in this group.
Yeah, we're keeping access open and taking away the specific reasons so people can actually just go and get the medical consult. I like that.
But
Yeah.
it's already, I mean, it's already been
that way.
happening, it's already that way, we're just making it clear.
Yes.
Again, the reason for this list is there some procedure that needs to pair with one of these diagnoses? If so, we need to know about that. Otherwise, all diagnoses are gonna get these services, right? No matter why you go to see your primary care physician, that's gonna be covered. You know, unless you're going every day for some minor condition or, you know, something unusual. But the question is, did we miss any procedures that are in our scope of work that we need to be talking about?
Yeah, and think of this as the foundation. Everything in the entire package of all of our services gets this. It's the foundation.
And stuff that's not even on the list, like heartburn that's a sign or symptom, would get the same set of services.
They're all, that's the foundation.
So
Well, and then we're gonna build rooms for this type of surgery, this type of procedure will be in addition to this.
And that's how it worked before, right? Because we covered diagnostic services.
again, this
Even
is
if
no
you-
change.
Right, no, I'm just re-emphasizing for those that don't use it every day, that's what was already happening. It's diagnostic, we don't have a confirmatory diagnosis, those were covered anyways.
Any other
Okay,
questions on this? I'm gonna move on to. So the next one is tension and cervicogenic
I did
headache.
have questions on that one before.
The
Yeah.
topic.
Yes, well,
Okay.
yeah, on the specific ones, yeah. Could you just tell me more about the removing self-measured blood pressure and hypertension and the interventions for congenital heart malformations? This might be, I'm hoping it's
So
a 2-second.
hypotension typically doesn't need remote monitoring, but if you want me to look into that, again, I
No,
can
it's just
flag it and
self-measured
pull it
blood
out.
pressure,
It's
isn't
right
that
here.
somebody checks it with a
Oh, so that
blood
would,
pressure cuff at their house?
yeah, that would be the DME that we talked about, so that would be covered as an ancillary service. Right, because,
But we're saying we won't cover it anymore.
no, all these things will get
No,
appropriate
there's
ancillary
specific
services.
self-measured blood pressure codes that
Yeah,
won't care, although
is that different? I didn't look up the code, is that different than somebody checking their blood pressure with a
I will
phone?
check, and that might be something that we just actually put into this group, because maybe we don't care why you're measuring your blood pressure at home. If you and your doctor think you
Well,
need it,
we just put automated blood pressures on an ancillary line, so
Yeah, maybe just make those codes.
them all on the ancillary guideline.
No, this is education and training to self-measure blood pressure,
Ah, okay,
and then self-measured blood pressure measurements. So there's two.
I made a note to myself to look at these codes and
Just
probably
make
make
sure
them all
those-
ancillary.
That they're all,
Yeah.
yeah, perfect.
And then there was a heart one.
yeah, so it was 1E of the things that you flagged. So I'm assuming because most of those don't need it, but it has
They don't.
other congenital malformations, and there's some that don't have great names or codes, I think, that would at times need interventions. Are we hoping that they have a more specific diagnosis, or that they'd be exceptions, or?
Cardiomegaly and other ill-defined heart diseases.
If it's
But-
easier, just vary at the top, the ones that she flagged, 1E is the summary. I had a question about it. It's like at the very top for the
Yes,
staff analysis.
it's the staff analysis. These were things that we've never gotten requests for any
Okay.
additional things.
Okay,
Um,
that's fine though.
if we, yeah, so it's
I was
like, that's,
theoretically
it's like
thinking through it, I
situs
didn't go and look at
inversus.
all the codes.
Yeah, it's like situs inversus. It's there. We
Right.
Don't do anything about it.
Right,
It's
no, I
helpful
was
to
thinking about
know.
the other congenital one, because there's some weird ones that don't have great. And I was assuming they probably didn't have specific codes, but
I
if you
will
got,
flag
if
this
it's not a problem, it's
to
not a problem.
look to see if any of these need any additional work on. So
Yeah.
what we'll do here, again, this is exactly what I want, flag for me the things that you want me to look into, there may be no change needed,
Right,
or we might
totally.
do something.
Yeah.
Thank you for finding that for me. I made a couple comments for myself. Overall, it sounds like you're comfortable with this paradigm.
Yeah, those were,
And
yeah.
you would like me to pull out a couple of things, and I will be happy to. Okay. Any other comments? The next one that we're gonna look at is a little bit different. This is the one where, so tension and cervicogenic headaches were on a medical only line.
That's page
below the funding line.
110. Thank you.
And there are, it was on a mishmash line, and there were acupuncture and osteopathic chiropractic manipulation codes. And they were there, the vast majority of things on that line, it was totally inappropriate to pair. So again, we're going back to how the list was kind of dysfunctional in some ways. Because we wanted to pair acupuncture with tension headache, it got paired with a whole bunch of things that we didn't review. So I pulled acupuncture for tension headaches out because we have previously reviewed it, there was good evidence it's effective, we want to continue to cover acupuncture for tension headaches. I wasn't going to pair cervicogenic headaches with anything but medical treatment, and a chiropractor reached out and said, no, there's good evidence, here's a bunch of studies that manipulation can be helpful. So I did an evidence review. So this is kind of more of the product that you'll see when something has been called out, or either by staff or by an expert and needed a little bit more review. So the proposed changes would be moving headache, because migraines have acupuncture. We already have a Botox guideline that limits Botox on that group to migraine, and you have to have certain criteria of migraines. And evidence, we have previously reviewed evidence that shows that it's effective. So that would be an additional, that would be added coverage, so it's called out. Similarly, osteopathic and chiropractic manipulation will be put into this migraine tension headache guideline grouping, with a guideline saying that it's only in that grouping for cervicogenic headache. So now you're gonna have all the headaches together, migraine, tension, cervicogenic, they're all gonna be in a headache group. It will have things like office visits, the foundation. It will have acupuncture to pair with only migraine and tension. It will have osteopathic and chiropractic manipulation to pair only with cervicogenic, which is headaches that radiate because of neck problems. There may be, there's Botox, which would only, there's a guideline, it will only pair with migraines under certain circumstances.
And regarding the manipulation, is that something that's been reviewed, or is that just something that,
So
that was advocated for by the chiropractor?
So the chiropractor advocated, and I looked at their literature, found other literature. So I updated my evidence review on the acupuncture. There was a recent Cochrane review for acupuncture for tension headaches, and it was effective. So kind of confirming, yes, we reviewed it before, it was effective, it's still effective, we want to cover it. For chiropractic manipulation, I did an evidence review. There was a 2022 systematic review and meta-analysis looking at 20 studies, about 1,500 patients. If you did manipulations over anywhere from 1 to 12 weeks, depending on the study, there was improvement in your cervicogenic headache for up to 2 years. The improvement was much more short and medium term, less long term, but it does appear that it's effective. And if you only need to go to the chiropractor once a year for, like a series of adjustments, and it's gonna help your headache for the whole year, that seems like a reasonable thing to cover. There is incident of harm. And with all chiropractic and osteopathic manipulation.
Especially cervical, though, it's catastrophic.
There is a difference between chiropractor and osteopathic manipulation.
Absolutely, they're not the same
data.
thing, and there is extreme harm that can come from cervical manipulation that is distinct from, lumbar spine treatments from a chiropractor.
The difference between high velocity, high amplitude, and high velocity, low amplitude is the differentiator in our language.
Okay, so I'm hearing, is anyone concerned with tension headaches being paired with acupuncture? So there's concern with cervicogenic.
And chiropractic manipulation.
And what about osteopathic?
I don't know as much about that. I don't know.
I wouldn't say I'm concerned, I'm just adding information and knowledge that there is a difference between those two approaches. And my understanding, given I went to an osteopathic school, right, they're gonna tell us certain data, is that the complication rates with low amplitude is significant. Though I think the outcome can be severe, I'm not sure the total number is severe in high amplitude. So I have to look at
So
that.
what I am hearing
The
is
knowledge
you all would
experience
like
I'm
me to look,
contributing is that the chiropractic population is definitely associated with significant harms. I don't know that the osteopathic is.
I did not look at, but I will look for harms and see if they outweigh benefits. I'll also look at private payers, which I didn't actually do for this. I will do a more of a review. I will assume from this discussion that you're all comfortable with tension headache and acupuncture. The cervicogenic headache is off the table for now. And what to do we will change code group 407 migraine headaches will be migraine and tension headaches. There'll be additional procedure or ICD-10 codes added to this group. We will not, at this point, add CMT and OMT until there's further review, but they're already acupuncture guideline. We need to change our acupuncture guideline. As you can see, there's really, if you could go down just a little bit.
Yeah.
There's a lot of word changes, but they're essentially, instead of saying included on a line, it will now be medically necessary. And instead of line, it will say code group. So we're changing the words, but we're not really changing the meaning. The only real change, if you could go down a little bit, for migraine and tension headaches, there will now be acupuncture is medically necessary for treatment of tension headaches as well as migraine headaches. So it lists both. So that's the only substantial change in this guideline, and then we will delete the below the line tension headache entry. I'm just kind of merging the two. It's not actually a real change in the guideline, but there will be a small additional coverage. And then the cervicogenic headache guideline will limit chiropractic to cervicogenic headache if we eventually decide that's what we want to do. If we decide we don't want to pair them, then that guideline will just be deleted.
So right now, am I striking this for the moment?
I'm highlighting it as a, yeah, that's, that one, that piece is tabled.
As part of today's vote.
And then there are a few other things, drug-induced headache, et cetera. They're not even gonna be in this group. They're just gonna be in medical management only, or the other option is we could just leave them in the headache group. Totally up to you all.
What's the practical difference of those two options?
Nothing? Do you wanna leave them all in headache?
It's a headache.
Okay, we'll do that.
So did we just add,
We add,
acupuncture treatment then to every headache?
there's a guideline that limits it to migraine and tension.
It should have pairings too, right?
Okay. Right, but if you don't want them to pair at all, we can just put them in medical. That might be cleaner.
That the student.
Oh, it would still
cleaner
pair
version.
because it pairs with the whole group, doesn't?
Right.
Correct.
Yeah,
So-
move to the other one then.
So if you want diagnosis is not even to pair, not even to get
Yeah,
to the
move it in.
guideline, put them in a different group.
I think it'll be easier for the systems.
Yeah.
Okay, so for this topic, if you approve it, you will approve the tension, the general concept of this tension migraine headache line. You will approve acupuncture becoming available for tension headache. You will have tabled cervicogenic and chiropractic to be brought back at a future date.
Yes.
And
Where
then,
did, where did the,
Ashley-
so the cervicogenic included the CMT and the OMT codes?
Yes.
Okay.
and then, sorry, did I hear Max suggest to move the non-tension, whatever headaches to the office visit only?
They're already there.
They're already,
Any other discussion?
I have a quick question.
Of course.
So outside of the headache, migraine, is chiropractic and acupuncture covered?
For other
otherwise?
things.
Okay, got it. We're just kind of grouping it as it relates to the headache and the tension.
Yeah, so I had thought about doing a group of things that could use acupuncture, but that would require a ton of work because we
Yeah.
already cover it all.
Yeah,
We may eventually, over the years, get to that point.
Trying to make sure there weren't other parts that we should also consider, but that clarifies it. We're
Yes,
starting
yeah, there
here.
are 20 lines of
Yeah.
acupuncture currently.
Yeah.
All of them are funded, so they'll just be converted to code groups and they will have acupuncture in them. over the years, it will probably be a good idea eventually to make conditions, benefiting from acupuncture code group, and then it'll be a list of diagnoses and then the acupuncture treatments.
Yeah.
I literally don't have the capacity.
Oh, yeah.
So,
Ariel, I wonder if that group might actually just be like alternative medicine or something so that you can make the bucket big enough to make your life easier. And I guess my other question, and this doesn't have to happen here, I'm just curious, in my sense of organization and just trying to master some of these concepts and language change, do you have like a tentative list of the groups that you're looking at that we could start getting comfortable seeing the buckets?
You are looking at the meeting Ariel and Liz and I are having next week.
yes. So, for example, in this packet was ophthalmology. They're talking to the ophthalmologists. Our list makes literally no sense to them. So they were like, why are all the cornea conditions on all these different lines? We do the same thing for all of them. So you'll see lines collapsing and there'll be all the cornea procedures and all the diagnoses that need them. And that's, I think, an improvement. Then there are things like what needs we have repair of bad baby hearts, congenital heart problems on like 20 lines. Why? We should probably put bad baby hearts, fix bad baby hearts in one group. That's a future problem. You will start to see code groups today. Most things are gonna be in medical management. There's a psychotherapy group. And then you'll start to see some surgical groups coming out too. And then, yes, I absolutely agree. We need to start having some type of master list of the code groups, and we will be working on that, and we will make that available to you.
It just sounds like a perfect topic for our retreat.
Sure. Are folks ready to move on?
Thanks.
Okay.
Are we
So-
voting on all of these at once?
That's what I was
think that was-
planning on doing.
Okay.
And
There's a
this-
lot to remember.
This one is then modified.
As modified.
Okay.
The next one is the prevention line with no evidence of effectiveness. So we have a
Page
prevention line, line
119.
3. Line 3 contains all the stuff that you guys probably do all the time. Mammography, colonoscopy, vision screening for kids, vaccinations. Those are all great. We know they work. We love them. We want them. Then there are some things that have been proposed over the years as screening that don't work, or they don't work well, or they may cause harms or whatever. So this proposal is basically to make most of these procedures what we would call not medically necessary. So to do that, there are the table here is actually pretty short. Most of these things will become informational. They're Z codes, and they're an encounter for screening of malignant neoplasm of skin. Most of these are not actually used as the primary code. And if they are, so if you want to screen for breast cancer with something other than an MRI or a mammogram, I don't know what that would be, but let's say you want to do crystal therapy or something, I don't know. We're not, that's going to be informational. It'll just be extra. It's not that we don't think some of them are important, like counseling for a family member or a drug abuser, but it's just that they're informational. They would need to have some sort of emotional distress, anxiety, depression, situational depression, whatever. And then the procedures, glaucoma screening for high-risk patients, that's actually not the code that's used for just glaucoma screening. So that's not medically necessary. And unfortunately, there are things like intensive behavioral therapy for cardiovascular disease is not used. We use preventive medicine codes. This developmental screening uses a different code. They've gotten a CPT code instead of a HCPCS code, and then unlisted vaccine. We might end up using that, I guess, if there's a new pandemic, but we're not going there in my brain. So most of what we don't want to cover for preventive is going to become not medically necessary. And then guideline note 106, which is our preventive services guideline, just needs those changes. Instead of included on line 3, it'll be medically necessary. Or instead of covered, it will be medically necessary. So those are just.
Ariel, and you're all gonna introduce this data.
Oh,
review.
yes. So we have been asked over the years, by hearings and by reviewers, to ask when was the last time HERC looked at this? And then staff needs to go look at minutes usually, or materials. So we're actually gonna put the date in the guidelines. And I think that will be really helpful, for the nurse reviewers, the people going to hearings, et cetera. Any questions about any of this?
This is Chris. I actually have used the just screening for malignant plasm for different things. Where would so would you then just go to you said there's better codes for that. Maybe you could just send those to me offline.
Yeah, so I tried to, like, screening for malignant neoplasm of rectum. There's already a colorectal cancer one, which is the code right above it. So most of these are just, they're the wrong code.
Okay.
And you're probably using the right code. If I'm wrong and you find out from folks that that is the code that is being used for something, please let me know.
Okay, I'll take a look. Thanks.
The next one, I thought we'd go through maybe one more and take a break. Does that sound good? So the next one is behavioral health conditions. So our behavioral health lines that are below the funding line are, this is a theme, big mishmash. So there's somatization disorder, somatoform disorder, chronic pain, a whole bunch of like fetishes and paraphilias, things like that. Most things that are paired with psychotherapy below the funding line actually don't have evidence really that psychotherapy is helpful. So I am proposing unpairing them. There's some exceptions to that, like there are some things that do have evidence of effectiveness and they will be pulled out into different groups. We have reviewed recently the personality disorders that are non-covered. We do cover already like borderline and schizotypal. The other ones in there have no evidence that that treatment's beneficial, or because of, like, what do you call it when somebody, they think that they're God, basically, like, they don't think they have a problem. So their narcissistic personality disorder doesn't respond to psychotherapy. So we've reviewed that recently. Somatization and related disorders was reviewed a couple of years ago. And they were found that they have evidence for somatization and hypochondriasis, factitious, and that they could be treated with psychotherapy, but factitious disorder and conversion disorder weren't effectively treated by psychotherapy. So essentially what I am trying to do with this one is pull apart the things that are currently paired with psychotherapy below the line and see which ones need to continue to be paired and which ones just need the foundational medical evaluation. And so all you need to do for this is the things that we have a new group called Conditions Benefiting from Psychotherapy. And I want to thank one of our public commenters. We had a different name. They suggested this name as being more appropriate for mental health. We totally agreed. Thank you. So conditions benefiting from psychotherapy are somatization disorder, somatoform disorder, and that's pretty much it. And then conversion disorder, uncomplicated substance use. So this is like people who drink and don't know it's a problem and they're not having any issues, and you just note in your chart that they drink alcohol. That just needs a medical management. Hypochondriasis will continue to not be covered. And then we're going to have what we call undefined conditions group. So unspecified mental disorder, unspecified, we don't know what that is. It's a dump code. So that will be an undefined. People need to give us a better one. And then insomnia is currently on covered in an uncovered line. It'll just be on the covered line. And there's already a guideline saying that they need to have cognitive behavioral therapy for insomnia as a treatment, where they can, or concurrent to medications. And that's pretty much this one. There are a couple of subtopics that have come out of this, just like the tension headaches did.
Sorry, the undefined list? So will that just be a list that doesn't pair with anything, so then we deny it because it's not necessary because of the pair?
Or we could put it on the medical visit only, if you think that somebody will code it and you just don't want it to stop billing.
That seems like that would be more efficient.
We can do that.
Cause you're asking what undefined mean?
I was like, yeah,
Will it not
what's
pair,
the
deny, or
function
is
of
it
that
gonna-
list? Is that different than,
Because we currently do have that, and there are some codes that are undefined that are there now, but I think I think that you're right. If you want to have an undefined mental illness not otherwise specified, if that's the code that pops into your
because we're
EMR.
gonna want people to look for a diagnosis, we wanna cover.
Right.
Is that different than the unspecified code group?
That was the same thing.
Oh, they have two different names.
Oh,
So there's
Ophthalmology.
informational and undefined.
Well, no, in the ophthalmology list, which we haven't gotten there, was one of my
Oh.
questions, there's an unspecified code group. Is that different than
names
undefined?
changed, it all is meant to be the same, but
Okay.
I can put them on office
That's
visits.
what, the question of what's that?
I'm
Okay.
sorry,
No, it's
there
fine,
are
it's
so
fine.
many of these and things have been shifting as I've been working
No,
on
no,
them.
no, this is not a criticism, this is just a explain to me, because I couldn't
Yep.
find it anywhere.
But
Okay,
I think that makes sense to put all the undefined things on medical management only,
I think so, I would like other
mainly
brains
because
to think
ICD-10
it
drives
through.
people insane.
At the
So,
same
Right.
time, we really do wanna encourage providers to use more specific codes, so should unspecified codes get office visits, or do they deny it, require them to find a more specific code?
Well, then the code's wrong, right? Like, 'cause
Right.
if you need to refer the patient to another provider to get the right diagnosis, you have to use an unspecified code.
yeah, and that
But it
came up
should
in the
only- it shouldn't
orthopedics
be-
review.
Yeah.
You're supposed to be using the most specific code you can. Yes, we don't have the
Okay.
greatest guardrails.
But we don't wanna deny an office visit if it results in
No.
unspecified
Right.
headache or something. So I will go back and anywhere you see now where it says undefined condition, consider that medical management. We'll go back and edit that.
I like that. Asking a lot of our primary care doctors to have that down on the very first visit. They need a place where they can then make the referral.
Yeah, and having worked with EMRs, sometimes if you just try to find a code and something random will pop in and you're like, whatever.
But that can screw up the referral if that referring
It will screw up the
group
referral.
doesn't want to see that code or isn't an expert in that code, it can send a patient to a weird place and actually delay the diagnosis, increase the care instead of the opposite. So, yeah, I think this is better.
Just are you okay with medical management as the bucket of
Yes.
everything, all of these like
Unspecified.
weird? There's some super like unspecified sprain of unspecified joint.
Unspecified.
I think
size.
that happens all the time anyway. I
Unspecified.
mean, our referral coordinators, that's like their daily life.
Unspecified joint?
Of unspecified size.
Yeah,
That
that's
might
what
be the one time I don't want to be. You can't figure out what joint. I mean, maybe if there's two in a hand and they don't
Unspecified.
know which one they want to choose. Okay.
I bet those
That does
codes
sound-
are, I don't know, I would say they're never used, but then I'm probably wrong.
Shouldn't exist, but yeah, okay.
Okay.
Yeah.
So I will make that change. There are a couple things that we will be looking at later. Fibromyalgia and chronic pain syndrome, which is a diagnosis code, it's not all chronic pain. They actually can benefit from other things. They were gonna be talked about right after this, but we have folks coming who are interested in testifying, so they're at the end of the morning. So if you happen to be like super interested in the lines that I just threw into this, that's where a couple things went. Okay, great.
So on that file, can you go back for a second? I should clarification. There was one place where it says like 201 in the third column, and I was just wondering if that's like a copy paste error.
No, that's, there's currently 201 is the obstructive sleep apnea, whatever, and the insomnia is there right now. It will stay in that group.
Okay, when we see that 201, so I'm getting good enough to realize.
I am
Look
trying to
down.
actually put the name, this one I didn't, but at the later ones, I'm trying to put the name. It may not actually keep 201, but the current line number is tentatively the code group number now.
Okay, so I'm just making, so I'm
So-
realizing that the pattern is if I go down and I see just a number, usually what that number is defined above, but I should think the same thing laterally as well.
Yes, exactly. So
Okay.
insomnia, the F
Perfect, okay.
51.01 insomnia are on 2 lines currently. We're just gonna put it on 1 line.
And that line turns into a code group.
Yeah.
Okay, that's, okay, so
We're taking,
so 201 and 599 will then get collapsed into 201, and that's what it's showing me in the third column.
Yes.
yes,
Perfect.
But 201 should be a name instead of a number.
well, it's next to it currently in that current line in the third column.
Okay.
But I will try to make sure that that transfers over to the 4th column for clarity.
Wait, the groups are getting collapsed or insomnia
Just
being?
insomnia,
Yeah,
insomnia
the
is
groups aren't getting merged, 201 and
so
599
the
are merged.
diagnosis that's currently on both the lines, it's really kind of useless to have it on the lower line now.
Because there's not funded and unfunded.
Right.
Or because
So
it's going
just
away.
gonna go to 599, so what's happening with 599? Sorry, I'm getting myself confused.
So
Nothing.
those codes will get the basic set of services, so
Okay.
medications, office visits.
Yes. The only reason insomnia is called out is because a cognitive behavioral therapy is very effective for treatment of insomnia, and we want to keep that paired. So it was put on the upper line to pair with cognitive behavioral therapy, and on the lower line for like daily ambient use. So that pharmacists, mainly for pharmacy, so the pharmacist could say, if you want daily sleeping pills, it denies because that's unfunded, and then, because the guideline says you only get them 4 weeks of sleeping pills.
I think I'm just gonna need to play out a little more. I'll keep thinking, I'll keep mulling.
Yeah.
I'm trying to keep all the patterns straight in my head.
What is there anything I can help?
Well,
to
like, so
reorient?
if this example, if we keep playing this one out, now with the new organization, would insomnia end up pairing with medication without that restriction?
It's still the same guideline.
But there's still a guideline, okay, great.
And the only thing that we don't want for insomnia, maybe, I mean, depending on what your pharmacy group decides, long-term medications, maybe that's appropriate. I mean, that's not our decision, that's pharmacy's decision. We want to pay for cognitive behavioral therapy as well as office visits. And then pharmacy can use our guideline and do whatever they want.
Okay.
And if there's some brain surgery that comes out for insomnia in the future, we would evaluate whether that's effective and see if it needs to be paired.
Good, that's helpful, thank you.
Any other questions? It is 10 o'clock. Do you want to take a break now or do you want to do one more? How do y'all feel? Okay, sounds good. Take a
It's
break.
exploding, but.
Yeah, so let's take a 10-minute break and reconvene at 10:10. Yeah,
We got through
it's
C.
fine. You will.
Yeah.
We got through D.
We got through C. Now we're on D.
Got it. Good job.
So-
Okay, 10-minute break.
Don't panic. It's confusing at first, and once you start to get the pattern down.
I think I was
I
following it, all the way to the back and started introducing numbers into the last column, and then I'm like,
And camera, I think.
How are we doing for people online, Kathy or?
You run the camera.
Well, I see Brian, Sarah. Any other members online that we can't see yet? There's Chris. Great.
I'm pretty much not.
Looks like we're very nearly all back.
I think we're all back.
Are we all back?
Mary, are you on the phone?
Mary, are you on the phone? Oh, yeah, there's Mary. Great, thank you. Okay, we're good. Let's go ahead and start back up. Thank you all very much.
Our next topic is chronic lower extremity vascular disease. And essentially, this is another one that's kind of status quo. I am lumping the, there's a covered and an uncovered or funded and unfunded chronic lower extremity vascular disease groups. I'm putting them together with a guideline.
I'm sorry, did we skip, Liz, help,
Did I skip
did
something?
we skip D?
No, we
Behavioral
are
health
on,
related diagnoses?
we are on the chronic lower extremity vascular disease.
Oh, okay, great.
Thank you.
Go ahead, Sam.
Okay, so chronic lower extremity vascular disease is things like varicose veins, which we have discussed at length in multiple circumstances. There's also phlebitis, which is vein inflammation, thrombophlebitis, and post-thrombotic syndrome, which is you had a clot, now your leg is swollen or something. And then there is we have several varicose vein lines. So the staff proposal is to combine all of the diagnosis and procedure codes from the current covered line, chronic ulcer of skin, varicose veins with major complications, with the ICD-10 codes from that are in the table. They're mostly from those unfunded 3 lines into a new group called chronic lower extremity venous disease with major complications and chronic ulcer of the skin. And then we'll do edits to our chronic lower extremity venous disease guideline and a compression of vein guideline. So the guideline note changes are pretty minimal. They're the kind of, instead of included online, it'll be medically necessary. We did, based on just a comment from someone, we had said that you had to try medical therapy or conservative therapy and fail. That was kind of considered like you're kind of blaming the patient. So we're changing that to treatment did not benefit the patient. And then there are a whole bunch of things that will actually be taken out and put into our evaluation of medical management. So if you've just got spider veins, varicose veins with no complications, all those kinds of things, they're pulled out. Varicose veins with major complications or with other complications will be in. So essentially the diagnoses that were found on the lower lines that were also on the upper lines will remain in the funded group. There's a couple, like hemorrhage not elsewhere classified as an R code, which is a diagnostic code. We'll put that there. We will exclude treatment of spider veins as being cosmetic. And then there's a couple of penile procedures that we, by rule, federal rule, can't cover. Treatment for erectile dysfunction, surgical treatment for erectile dysfunction, so they're not medically necessary.
Very, just so I don't forget, can you scroll up one? On the other penile code, that book right there, the vascular disorders of male genital organs. We're keeping that,
The diagnosis we're keeping.
yeah,
But then,
and pairing it for certain interventions.
oh yeah, sorry, there's paired for all kinds of interventions.
Is
It's
that-
the arterial revascularization that we're not doing.
Okay, is that, so I was just checking on what that code meant, it looked like it was for like hematoseals and hemorrhages and stuff, that's used for? This is kind of a weird code, and I wasn't sure
Sometimes
how
we're
it
not
was
sure
aligned.
what it's used for. But it's on the covered line, we have guidelines about spermatoseals. And
Okay, and it's been part of that, okay, just cause it's a general code, I wasn't sure how that overlaps with the ED stuff too, and that we're keeping it, okay. It's something that's used for some functional thing, we've looked at billing, people use it for a funded reason.
So the N51, I'm just gonna flag it, I will look and see what it's
Okay.
used for.
Okay, perfect, thank you. That was weird, it was on lower extremity too.
It's
It took
already
me a
on a
minute to-
covered line.
Yeah, it took me a minute.
Okay, so when you guys, if you want to approve this one, N 51.1 is out until staff look at it a little bit more.
50.1, yeah.
And I will just make sure that it only pairs with things that might be appropriate, or if it's not an appropriate code for any surgical management.
Yeah, because it's kind of, yeah.
The fact that
kinda
it's
general.
on both lines makes me think there's, and we're gonna get to urology maybe later, there may be a explanation in the guidelines there.
Yeah, just worth asking.
Um. Okay, any other questions or concerns about low extremity vascular disease? Okay. Moving on, everybody's favorite, spinal procedures. So this has a lot of technical changes, but nothing is proposed for really change in what we cover now. We do have back surgery on a whole variety of lines. There's an abscess line for, infections of the back. There's fracture lines, there's osteomyelitis, which is bone infection, cancer. So there's a bunch of lines that have back surgery codes that are appropriate because of a particular infection or cancer and other disease product. So we're really talking about back surgery for low back pain, radiculopathy, nerve compressions, those types of things. Looking at the evidence, there's a 2021 American College of Occupational and Environmental Medicine, their low back pain guideline. For vertebroplasty, they looked at high quality sham controlled RCTs, and they didn't find any improvement with vertebroplasty. And for kyphoplasty, also, they don't recommend it, low confidence that it's actually beneficial. And then just reminding you, Chow in 2015 did a systematic review, I think either for HERC or it was one of those big systematic reviews where they looked at things and found that epidural steroid injections resulted in some immediate relief pain, but benefits were small, not sustained, kind of unclear whether they were clinically significant, and they didn't impact whether the patient eventually needed surgery. So essentially epidural steroid injections might give you a few days of pain relief, and that's about it. So the recommendation is to create a new code group, conditions of the back and spine with surgical indications. We're going to pull everything from line 343, which is our covered back surgery line. There's a couple of diagnoses that will get added. And then we're going to include all of the CPT codes from the unfunded condition of the line, that the 523, except the epidural steroid injections. And there was a denervation code. Those are going to be considered not medically necessary. So currently we say they're not medically necessary by putting them in a blue line. Now we'll put them into a not medically necessary.
And the denervation, has that been reviewed?
That's, yeah. If you don't do the epidural steroid injection, you really can't progress to that. They have to do a trial. And they don't work very well either.
Isn't it the set and MDBs?
Yeah.
Yeah, lead to the RFA, epidurals.
Yeah.
Sometimes the spinal injections though are very diagnostic, like if you're trying to figure out like what is causing the pain, then, but that could just be a local injection. So would a spinal injection with just local medication and not steroid be covered for diagnostic purposes? Sometimes these are diagnostic, not therapeutic procedures.
As far as I'm aware of them, they're diagnostic in terms of then leading on to these interventions.
Right.
They're not, and that's it. If the interventions aren't effective, I think the question of the diagnosis is questionable because it's looking at those, like the point of a medial branch block is the pain coming from that facet, right?
Yeah.
And if the intervention isn't effective, I think it would also call into question the diagnosis of that intervention.
Sure, yeah.
And so I don't think any of them would be
Okay.
covered. I don't think they are. So I think it's all the same code. But that also kind of gets into the central versus peripheral pain sort of thing. But if we're looking at just that specific one.
Holly, does this come up a lot? No?
I don't ever get requests for lidocaine only, ever.
But you do for epidural steroid injections.
All the time.
Yeah.
So it won't cover that.
Right.
Right, okay.
And then there's a whole bunch of guidelines that just need formatting changes. And then there were some spinal fractures that were below the funding line. So I'm kind of consolidating them with the above the funding line into a new code group, vertebral dislocations and fractures. And yeah, so, we have our PT/OT guideline. This guideline is under review by OHA about whether we want to change the numbers and whatever. So this might change, but these changes are just the, not medically necessary instead of covered, not covered. Conditions of the back and spine, everybody's favorite guideline 37, will not change except for the wordings there'll be technical changes to the wordings. But we will put in 2 additional not medically necessary because we're putting them there. That's the corticosteroid injections for low back pain and the diagnostic anesthetic injections. That's what we were just discussing. Those will be called out so that it's clear that we don't pay for those, and they're already in the guideline. Just saying that they're in line, now we're just gonna put it into the we don't cover it, like, list, which is probably where it should have been in the first place. And then opioid.
On the fracture line, you made a new group for fractures and dislocations. What procedures do those pair with? Because you said some of those diagnoses were below the line.
Right, they're below the line for kyphoplasty and vertebroplasty, which we're gonna not medically necessary.
Okay.
And a lot of them are things that are more minor that probably don't need much, but at the same time,
Right,
it's bad to say like a small fracture of your cervical vertebra is not covered. When all it really needed was an orthopedic visit, maybe a CT scan, maybe a neck brace.
That's what I'm trying to figure out, because like compression fracture, like osteoporotic compression fractures, right? with no
Right,
others,
so we're gonna continue to cover
Right.
DEXA screening, medications if like you're on a bisphosphonate because you've got a compression fracture.
Okay,
It's basically trying to keep them the same.
okay, there's no other. I'm just thinking, because more severe fractures could have an intervention that were appropriate, but like the osteoporotic fracture, not, and if they're all in the same group, then they don't pair with the same procedures.
We'll take a look at the table and maybe osteoporotic compression fractures just need medical management.
Oh, okay.
Smoking and spinal fusion doesn't need really much change. Artificial disc replacement, just technical changes. Vertebroplasty and kyphoplasty. This is actually, so we do have extremely limited coverage currently for vertebroplasty and kyphoplasty. If it's on an unfunded line, so this is mainly for hospitals because it basically says you have to be inpatient. So we can discuss whether we even need this because once you're inpatient, we don't care in a way, but we could leave the guideline to basically say if you're bad enough off that you're in the hospital, even if it helps temporarily and you can get out of the hospital,
Right,
we
I
wanna
think
pay
that's
for it.
important, good, I'm glad you have that, and I mean, you have vertebroplasty and kyphoplasty listed, I think there are differences, and differences in the literature, especially with safety in terms, but.
That's
yeah.
how it is currently.
Yeah.
Do you think we should do something different?
Yeah.
Okay.
Yeah, I think it should be kyphoplasty or kyphoplasty.
Just kyphoplasty, not vertebroplasty?
Yeah, vertebroplasty is injecting cement into the spine.
That's the dangerous one.
And without any sort of containment device, whereas kyphoplasty, you similar like technical technique, you cannulate a pedicle and there's actually a little like balloon deployed into the vertebral space that then contains the cement. So there's a lot lower risk of like cement ending up in the say vena cava, for example, which happens with vertebroplasty. Kyphoplasty is also done like in a surgical setting with anesthesia, or vertebroplasty is typically done by radiology. So there's a totally different complication profile, and in general, I think lots of payers have dropped vertebroplasty to the point where I don't even know if it's a skill subset that's being taught.
So
whereas kyphoplasty in these extreme situations of patients with severe osteoporosis who are bed bound, kyphoplasty is used as like a
So right now we have
way to mobilize
sacroplasty is not covered on any line for coverage consider. I actually need to change some of this. I didn't notice that. I can move vertebroplasty and basically say sacroplasty and vertebroplasty are not medically necessary.
Correct. and just in those rare.
Are we just making this change right now?
No, I'm
Okay,
bringing this
you're,
back.
you're reading this back.
Yeah,
Okay,
we
so
have
we're
a
just gonna-
coverage guidance on this, will need to retire in a few years.
So we're tabling this.
We are,
Entire issue summary?
why don't we, we'll table the entire issue
Okay.
summary,
Okay.
just,
It's not just.
Yeah, so we do allow, I think this was the compression fracture. We cover treatment of collapsed vertebra if the fracture is a trauma injury or has spinal cord injury. Because you can get a compression fracture from acute trauma. So that's, I think, that can be the protective bit. But if there is something that's like specified, like osteoporotic compression fracture,
That would be the indication.
but then we want to do vertebroplasty, so we want to keep it in this group, or maybe make its own group. We could just have a vertebroplasty for spinal compression fracture and have a guideline. It could be its own little mini group if that works better.
It says treatment, are people gonna confuse that with, because there's like medical treatment for an osteoporotic fracture. think we
We
need
could say
interventions,
surgical
right?
treatment.
And we keep these not to advise hospitalizations, but to advise outpatient treatment,
Yes.
essentially, yeah. fair.
Although I think it
To
might be
restrict
useful
outpatient
for the kyphoplasty to still be, even
Yes.
as an inpatient one, just to clarify. We have very limited coverage, but we do have some.
Because people order it on not admitted patients, so that's why it's helpful.
Well, the guideline
Right, that's what I was thinking, it's right.
specifically deals with that, I think.
Well, if it says you have to be admitted if you're ordering an
It has
outpatient.
to
then
be
it would
admitted,
covered.
that's-
Yeah, so I was trying to think, why do we have that? People are just gonna get admitted now, no, they still make sense, yeah.
That was my question to you all. Do you think you still need it? It
Yes.
sounds like
Yes.
it would be helpful.
I'm thinking through the answers, yeah.
Yeah. Tethered cord, again, technical changes. So then there's so some of these things, like they're unspecified, but all the specified ones are in a covered. There's fatigue fracture of vertebra. Would that be, we're talking, then there's collapsed vertebra, wedge compression fracture. I'm not sure if I can look to see if any of these are osteoporotic, but most of them are like wedge compression fracture, which I guess could also be trauma. So we probably want to keep the current guideline and just maybe even clarify osteoporotic fractures are not, have no surgical
Can I
treatment.
just look at that group and make sure we're differentiating between kind of ones that recently do need surgical interventions versus just outpatient treatment?
Okay, so all of the compression fractures right now would have surgical treatment if they are meeting the guideline note, which was trauma system injury or spinal cord injury.
Why do we differentiate trauma without neurologic injury?
Mm-hmm.
Or just have spinal cord injury?
I am not a trauma nor orthopedic surgeon, so there could be. things
Some,
I'm not
that
thinking of,
guideline's
but-
been there for years, it must have been added at some point, someone thought trauma entry was a criteria.
Like, I get why you want trauma, but are you doing surgery without
Right, so-
neurologic complications?
Yeah, sometimes when people are polytrauma patients and they have multiple organ system damage, that surgical indications for the individual injuries change because there's so many injuries that it makes sense to be more surgically aggressive than less to facilitate
Yeah, I think
mobilization. So
that's kind of where it came
that's-
from.
Okay.
You've got a
Okay.
broken
Okay.
pelvis, you've got this, you've got that,
There's a
we're
floating
going.
shoulder and there's also a
That makes a lot of
scapulocaudal
sense.
fracture, then we do fix humerus fractures, right? So
Okay.
sometimes the poly injury nature of the situation changes the surgical implications. So I bet that's where that came from.
And that's again gonna be, I'm gonna assume if you're in the trauma system, you're getting this care in a hospital, so.
Yes,
Yeah, which is-
that's the criteria of admission actually, is that trauma activation, right? So, yes. It's a little bit redundant, but it's clear.
Okay, so it sounds like, let me make a note for myself to make sure that there's no, I wish they had something like osteoporotic fracture, but I will
Yeah, I don't
look.
think you can differentiate what they're meaning by code.
I don't think so, but I will make a note for myself. Look to see if any code specific for osteoporotic carotid fracture and
That's,
exclude from treatment.
I had another thought.
Who's defining trauma with this trauma specification?
Because we're thinking like hospital trauma, you call it code trauma, right? That's a pretty defined entity. But the word trauma just means,
Trauma system entry,
Yeah,
yeah.
that's what it says.
Oh, so it's trauma system entry. Okay, never mind.
That's when you
Okay.
get that special
Okay.
bracelet and you're like in
That's
the.
totally different.
when like
Yeah.
700
Good,
people
good,
get
good.
paid when you're.
750
Yeah.
people.
The ER.
Code trauma.
Everyone in the
This is when
hospital
my
is paid
4-year-old
to the
fell
ER.
12 feet and I took him to the hospital by myself and I told the triage nurse he fell 12 feet and all of a sudden like
Trauma
it was a trauma activation and bells and whistles went off and all sorts of stuff. And I'm like,
We fall tonight.
Yes.
he had a major injury actually, so I mean, it was a good call, but
3 or 4 days. Yeah.
It's probably a bit startling.
but yeah, it just never occurred to me like, oh, I should have called like EMS and put him on the back ward.
Next time.
Just walk him in.
Okay, so this entire topic I'm tabling and I will bring back after I look at, I have questions about kyphoplasty and vertebroplasty. I have questions about making sure there's nothing like an osteoporotic fracture. Just a few things to verify for you all, and I'll bring this back. I think it'll be pretty straightforward when you see it again. Okay. And then the next one is general surgery. This is my other PTSD, it includes all the hernias. It's essentially status quo. We are not going to add coverage for ventral hernias because there's new evidence review that I'll briefly go through that shows very high rates of recurrence, like up to like 70 or 80. I mean, it was higher than I quoted before. So we're continuing non-coverage. Of course, there can be an exception for whatever indication. There's a digital nerve injury thing that was this whole specified thing, we covering nerve allograft, blah, blah, blah. That actually is a pretty standard therapy for digital injuries because of the need for finger use. So that would be an added coverage. I think that's, you'll have to take a look at what I.
Was that different than the guideline that we already had?
I think there's some minimal changes.
Okay.
And then there's a lot of stuff that will stay the same, but their names will change. So we have a little box here just to help you all, because this is such a hot button area. Ventral hernias, no change, not medically necessary, high recurrent complication rates. Cholecystectomy, same guideline with the edits that we did a little bit earlier. When we did just, I will have to flag that we changed it, change guideline in an earlier issue.
April?
But we already have a pretty good guideline about when we cover it and when we don't.
April, is the general surgery the group?
Yes.
Okay, thanks.
So yeah, the names of the bigger groups are because that's the specialist I talk to. So orthopedics and sports, you'll see like there's enormous mismatch, the same with ENT. That's the group I consulted. So this was general surgery, although we didn't consult general surgery because we didn't feel any changes were warranted and we didn't want to get into a long discussion about changes that were probably not going to be made. And then there's a bunch of other general surgery conditions that really don't need more than the medical management. So for the ventral hernias, there was actually a new study of about 30,000 patients, a registry study that came out like a month before I did this, like in November. And the recurrence rate was really high. I mean, it ended up being like 71% or 74% within 5 years. I've always quoted people like 30 to 40%. So 40 to 70% of patients will need re-surgery within 5 years. So I don't know what we're doing for them. Anyway, so we're going to create a new code group called, it's essentially the same thing as our current line 167. So remember I said that a lot of these things are going to
this may end up with the same number, 167. It's essentially the same group. We're gonna put in complicated and uncomplicated hernias. The covered and the uncovered line will merge. And then there will be a clinical guideline that will say when we do surgery. So we don't do surgery if there's no obstruction, no whatever. We don't do surgery for ventral hernias, full stop. And then we're gonna do a gallbladder line. It's gonna have a covered line 55, as well as some of the codes from the non-covered gallbladder. So gallbladder becomes one thing. And then a lot of these are just gonna be medical management only. And then quite a few of these actually appeared in our open wound, the nerve disorders, because they would normally be from trauma. And so they're already there. And so anything that didn't appear on 206 is medical management only. Anything that did appear on 206, which is the open wounds, will just continue to appear on 206. So that if your nerve is cut with everything else in your arm, the surgeons will fix all of whatever they can. So complicated hernias, again, this is where I started putting in treat surgically, so thank you for calling that out. So, we want medical management of an inguinal hernia. If you need a brace or, those braces, or you just want a visit, whatever, an ultrasound, whatever. But surgery is limited to the current criteria, which is a little bit different for children than adults. And then ventral hernia repair is just not necessary. And then cholecystectomy, the guideline that you see here will have the edits from earlier. And I actually made a note to myself to look for that, so good on me. So you're not approving the exact wording here, you're approving just the technical changes that might not have been, that weren't in that issue summary because they still have lines. So this guideline doesn't take effect till 2027. So the changes you did on the current guideline apply to lines. And then when it merges over in 2027, it will have these not medically necessary instead of not included on lines. We're gonna have 2 products for a year. We're gonna have the list and we're gonna have this.
Random technical staff question. If we want data blast review in January 2025, but this goes into effect January 2027 for deals to be won at 5 years and onwards, should the data blast review be January 2027? No.
It should be the review.
The date that we discussed. Because next year there might be a study that's groundbreaking that comes out, even though it's not in effect yet.
But just, I was wondering about when we publish this.
So peripheral nerve injuries, we treat acute, but after 6 months, sorry, it's not gonna work, so we're not gonna cover it. Nerve allografts will be medically necessary for digital nerve repair. And then there's a law that was on the surgical lines that will become evaluation and medical management only. A lot of these are pain, neuropathies, things like that. And actually looking at some of these, this is where staff is gonna have to do some behind the scenes work. A few of these I actually put into the PTOT group when I talked to the sports medicine folks. So at most, a lot of these things will get PTOT. But mostly they'll just they're not gonna get surgeries. So some of these neuropathies might get PT.
No nerve decompressions.
Right.
And that's been reviewed.
That currently wouldn't get them. So there's a lot of diagnoses that are already covered. These are more of the unspecified and just lesions and things like that.
So if you think some of these need review, that's what we need to know.
I don't know the literature on it, but I certainly know that nerve decompression is surgeries. We do that surgery from time to time.
Is there somebody we should talk to?
So the nerve compressions, it's the more generic. So IC10 sucks, especially for ortho. I'm sure you're aware. So the covered nerve compressions are probably something like L4, L5 nerve compression. And then this one is just a dump. You got a nerve compression somewhere. So a lot of that's why they were probably below the funding line and nobody complained.
But for example, neuralgia, paresthetica, or lesion of sciatic nerve, like those are both situations where we'll do like decompression, like there's some deformities of the piriformis tendon where the nerve pierces the tendon and then the tendon compresses the nerve and that requires a surgical sciatic nerve release. It has nothing to do with lumbar spine. Same with neuralgia paresthetica, strangely, it can be really, so if your lateral cutaneous nerve crosses right over your ASIS of your hip and that's where your belt goes, it can be extremely painful and there can be scarring.
What do you do?
Just decompress the nerve, sometimes like get it out of the scar tissue, move it over a little bit. With the sciatic nerve, it's a piriformis tendon release and dissection of the nerve free to make sure.
Okay, so that sciatic nerve is not the nerve release, or it is the nerve release?
Well, basically, that's what the surgery is like, nerve release. You know, there's specific, depending on the circumstances, specific thing you do. For the sciatic nerve, it's also often the piriformis tendon, but it could be elsewhere. If you have like a hamstring injury, hamstring can ball up and wad around your sciatic nerve, and that can cause sciatic nerves. So there's all sorts of, like, it's rare, but there are reasons. Same with the perineal nerve in the lower leg. There are conditions where
do you see perineal nerve?
I don't.
Okay. So I have those two diagnoses flagged, and
Okay.
I might reach out to you to make sure I get them right.
Yeah, and again, I think at least it's worth looking at the literature to know if those are effective surgery.
Yeah, no, this is all this is exactly what I want. I want you to call out, check on this.
Perfect, okay.
And then I put your name down as the person.
Yeah, sure.
Thank you for your service.
Yeah, and then, all of our, we're no longer, yeah. And then there was, the only two procedure codes that are unique to an unfunded line in this group were these, nerve repair. And, I'm putting those on the people in one line, they might be needed. So I have those two diagnoses flagged to be looked at. Any other question, and then I have flagged to make sure that cholecystectomy guidelines stay consistent. And any other things you want me? So what I'm planning on doing is in March, you'll see, rather than this whole issue summary, you're just gonna see those couple diagnoses called out and a little. So you can approve this minus those two things that I pulled out for further review. So we'll just call it proposal is modified.
It's gonna be hard to remember.
Ariel,
all these
can I
things
stop?
at one time, but
Yes, Chris? Go ahead, Chris.
I just was curious for an organizational question. I'm still trying to just wrap my hand around like what has probably been rolling around in your brain for quite some time, and I just appreciate the effort of this whole endeavor and your time. What I'm seeing is like there's the group is general surgery, and then below that group we have guideline notes, and within the guideline notes you call out kind of more specifically based on the procedure or treatment, whether it's medically necessary or in this case medically necessary for surgical treatment, not medically necessary for surgical treatment. And then for those things that are not medically necessary, that are already like they'll all kind of fall into that evaluation and management only bucket, which is the big long list. Are those the three buckets that I'm seeing coming out? Is it for procedure and treatment, or are they more for the conditions below the general surgery? That's where I'm not clear.
Yeah, so how this is structured is I took the list of uncovered lines and I lumped them into specialty so that I could consult with specialists and have them just look at their lines rather than look at all of the lines. So you'll see general surgery, I took out really disparate, gallbladder surgery, hernia surgery, and nerve repair. Those were sort of surgical things. And then everything is staying the same. In other words, things that were on non-funded lines that we don't really think need surgery are going to be medical management. There are some things that we have on, in this category, there was quite a bit where there was a covered and a non-covered line. And our paradigm now is we cover things on the covered line for these procedures that are only there, or for procedures but only with this guideline. And then the non-funded is they're not paired with those procedures, or the guideline says we don't cover them in these cases. So that you could deny something because it is not funded. We're not doing that anymore. So I've collapsed in a couple cases, the hernia and the gallbladder, they're gonna be collapsed back together. And the guideline, rather than saying it's on the funded line for this and the unfunded line for that, so that the judges can say whether it should be denied or not, it'll all be, you can take your gallbladder problems will be paired with gallbladder surgery, but our guideline will say when that should happen.
Okay, so it's kind of condition plus.
So in the basic structure, the medical visit only, it will be condition and pretty much no procedure. Then there's gonna be a lot of these like hernia surgery where it's condition, office visits, no surgeries. Obviously, that's the basic, everybody gets that. Plus surgery. And if we don't care, because the surgery is always effective or we don't see any overutilization, there may be no guideline. It may just be, you can have surgery when the surgeon judges it necessary. If we see that it might be overutilized or we have concerns or it has a lot of harms, there'll be a guideline that will further
And this is
explain.
Okay.
very similar.
Going
to
through
how the
that really helps me. Thank you.
It's the same as the funded region works today, essentially.
But if we don't make a guideline of this, TCOs review them individually, so they can use their own clinical criteria.
Yes.
They can.
You-
Right, but I wanna make that clear, it's not like we pay for anything if there's not a guideline notice.
Right.
It's left up to the CCOs.
Yeah, so you can use external criteria
Right.
as long as they are aligned with that.
They're still
definition of
medical
OAR.
necessity.
Because
Yeah.
because it's too expensive and we don't wanna give it to you, that won't work.
Right.
As long as it aligns with
Yeah.
that
Right.
rule.
I'm just making that clear.
Yeah, it all
It's
has
not,
to be,
we don't just pay for
it still has to
everything.
be medically necessary.
Right.
And we can make those determinations.
Yep.
With evidence-based reviews.
I want to make a friendly amendment to skip ophthalmology for now because that goes down a rabbit hole. Let's go to breast surgery, which I think is a lot more straightforward. I'm trying to get all, like, as much of the straightforward stuff out there before we start getting into stuff that might be rabbit hole-y.
Page
So-
257.
Thank you. So there is currently a couple of conditions of the breast that we do not cover surgery for. A fistula, which is a type of abscess, so that needs treatment. Fat necrosis, which can happen after surgery. It can happen after trauma, like a airbag going off. It's basically the fat in the breast, which the breast has a lot of dyes, and it can become a lump, it can become painful, it can look funny on a mammogram. We currently would let somebody have all the testing done, but they can't have treatment. The breast surgeons had a pretty good case about when they do operations for that. They don't like to generally, but there's a few times where they feel it's appropriate. Minimal changes, all of our cancer, we have a very comprehensive package for coverage of breast cancer. We are not touching that. There's a prophylactic, like if you have a BRCA gene and you want a prophylactic, great. And then we talked about a couple of things that came out of this. So I talked to Dr. Sarah Walcott-Sapp, who's a breast surgeon at Providence. We've already addressed a couple of her issues. We weren't covering aspiration of breast cysts. We did that as a straightforward item last fall because it's diagnostic. And then I did consult with breast oncology surgeons. They weren't interested in meeting because they felt that our current breast oncology coverage was very adequate. They didn't have any input. And then the fat necrosis was requested because it can be very painful. It also can be a bit of a diagnostic challenge, or it can just be extremely anxiety provoking for a patient who feels they have a lump or something. So we are gonna have a breast cancer line, and it's gonna continue to have everything that the breast surgeons feel we need to do, and we're changing our we don't have any restrictions on any of the breast surgeries for cancer. You can pick and choose. Now that we don't have any restrictions on acellular dermal matrix, the surgeon and the patient will pick and choose which procedure is most appropriate and whatever. For prophylactic, so when you get MS, you're getting your breast removed for prevention of future cancer, we're covering that when it's appropriate, which is no change from current. Breast reconstruction, we're continuing to cover just basically technical changes. Breast surgery revision, again, technical changes. One place that this is gonna be super helpful is we had a very long, multiple meeting discussion about breast reduction for macromastia. It's on a lot of lines because we had different indications. It's now gonna be just in this, so we're gonna have 2 breast surgery lines. One's gonna be cancer or high risk for cancer. The other's gonna be no cancer, but you need breast surgery. And so breast reduction for macromastia will fall in that second category. There's a few things, again, going through with the surgeon, she felt she doesn't even see her PACs because it doesn't need any surgical interventions, so. And a few of these, if you go down just a little bit, you had mentioned someone had mentioned about covered things, so N61.0 mastitis without abscess, we already covered that. I was trying to figure out like, why do we cover something, but not other things that look like abscesses? So that's more my work and just to be clear for you all. And then if you have an abscess of the nipple, hypertrophy of the breast, which is the macromastia with the guideline, a fistula of the nipple, fat necrosis, those things are all available for the non-cancer surgeries. Mastodynia will be converted to diagnostic workup file. And there will be some procedures that will be moved into one or both of the breast cancer lines. So all of the procedures will be covered, except one that we have in our excluded guideline 2 will stay in excluded guideline 2. We found evidence of, I believe, harm at some point. And then mastectomy for gynecomastia, so it's not macromastia, that's just people who have their breasts enlarged, usually from medications. That's not medically necessary, it's considered cosmetic. And then breast augmentation, we're not gonna cover for, we're only covering for usually it's the contralateral breast after breast surgery when they need for symmetry. So it'll be only on the breast cancer line.
How does the diagnostic workup file work now? Because if we're covering everything for visit and evaluation codes, isn't that group by definition covered for diagnostic
Yes.
procedures? So how is
Good
the
point.
diagnostic list different?
That's a good point. We could collapse them.
Unless there's a difference. I'm asking questions to make sure
Yeah, why-
that things
yeah.
that other people haven't thought of.
It's because I think that there's diagnostic workup to get to diagnosis, but once the diagnosis is gonna be not necessary or whatever, further diagnostic workup will be approved for that, like a second stage,
I
but
don't know if
not
our
on the top.
coding's gonna be set up to catch that. That seems like a lot of work to separate those out.
Mhm.
Because I think there's gonna be a ton of overlap between those.
Yeah.
Yeah.
Okay,
Yeah,
so
for
what I'm
sure,
gonna do is
it's probably versus-
mastodynia will be evaluation and medical management.
Yeah, I don't think we need a diagnostic file anymore.
There may be reasons we do, just because of but yes, we can, there's certain things that are only covered for diagnosis. And then there's certain, in the diagnostic workup file, I don't believe you get medications.
And I think specific
You wouldn't.
diagnostic things then are like tied to,
There's a diagnostic file, which is the diagnoses, and then a diagnostic procedure file.
Right, but those also kind of don't matter because there's no OAR that supports that.
I will talk to the whole
Yeah.
larger group, because we could condense, if that would work, we could condense diagnostic down to.
well,
Because I know we talk about those, like, yeah, the diagnostic code group says it's covered if you're doing something in a diagnostic workup file. but those comments are irrelevant because that's not supported by OAR. So, and the OAR just says.
Yes, there's a lot of overlap, but you're gonna want that distinction just insofar as like further diagnostic workup of like, what's a condition that we would consider that necessary to continue exploring, like.
Well, I mean, once you have a diagnosis, you have a diagnosis.
Right, nothing comes to mind. I get that example, but nothing comes to mind, and I've always had this problem with those lists because they're not, we have to follow OAR. The judges don't care what the little codes are in our code, what the sentences are in our code groups. So they kind of were irrelevant because if somebody orders something as diagnostic, it doesn't matter where that code falls.
So we have a whole group that's working on this and related questions. I will bring
Yeah.
this up is, can we fold the whole diagnostic group into the office visit group? Would that, there
Yeah,
may be things I'm not thinking of.
totally, that's what I'm asking,
And
yeah.
and we have people in that group who are like the MMIS owners and the policy like writers of stuff, rule writers.
Yeah, I'd like to simplify it, because those, I think even now, all those separate code groups are really confusing, because we can't uphold any of them.
I think that is a really good point, and I just highlighted it.
Yeah,
I
they're
will-
hard to find, because it's gotta look at the list.
We have heard that
You
for
gotta look at the
years,
guideline
that
note,
they're
you gotta
hard
look
to
at these
find.
other lists
Yeah.
that aren't associated yet.
And if we don't care why you get a chest x-ray, why would we office visit only, and you get a chest x-ray for your ankle sprain, oops, oh well, I mean.
Yeah, hopefully if there's utilization review, we can catch this. with something
I don't think
right?
anybody
But
cares why you get an
I guess
x-ray.
here's you put a chest X-ray and diagnostic workup file, but a very specific diagnostic test, you wouldn't necessarily want that collapsed and put in a thing. Like you can just use that for anything. A very specific thing you'd already want on like a code group to further refining of like.
We do have some
like
diagnostic
cancer.
guidelines, but maybe we could have a special smaller code group.
Yeah,
I
at
will-
least
I will
simplify it or cut it
talk
down or
to-
something, yeah.
Staff will kind of noodle on that. We'll talk to our larger group of people.
Yeah, I'd have to, I don't want to, but yeah, just front of mind, I think that's worth discussing.
So, yeah. So for this topic, I have one change, which was the master dining will become
Before we do
office
that.
visit.
Next, so if we were to take, there's a bunch of procedures that are both on the diagnostic file and on almost every line of the prioritized list.
Office visits.
If we were just to put those on the diagnostic file, leave them off anything HERC does.
I'm sorry, Jason, this is Daphne. I can barely hear you.
I'm sorry, so if we were, there are a number of procedures, there's several dozen that are on almost every line of the prioritized list and on the diagnostic procedure group. This is not diagnoses, these are procedures. Could we just put them all on the diagnostic procedure? Is that what you're talking about, or are you talking about the diagnoses?
I would be talking about the opposite, getting rid of that list. I guess the value of that list is initial coding, right? It's like an initial UM step, to say it's appropriate to do these with these diagnoses and then.
Yeah, because there'll be
Get you a
things like
code.
like a screening colonoscopy is paired with need for lung cancer screening. I mean, there's.
Right. It's probably not helpful for us clinically, but it is helpful for billers. Now that I'm thinking about it, would be my guess.
Yeah.
So I would still ask.
And your
because
systems
that's
may not be set up for it now, but like post 2027, like operationally things will change and if we like lose this distinction now because it got all collapsed.
Right, that might be a bigger headache.
Issue.
Think about it,
Yeah.
but what I'm taking away from this discussion is places where I've suggested something be on the diagnostic file, I will put on the medical.
Yeah, in
management file.
that case, yeah, yeah,
This is Chris. I'm trying to think about that question. And the only thing I can think of is, and I don't even know if it's relevant to this time point, but like we had mammograms where the technology went from 2D to 3D and the 3D wasn't covered, but the 2D was, and there's a cost difference there too. Is that the kind of thing that you'd want something specific for?
In that case, we would either write a guideline saying we only cover the 2D, not the 3D, or we might put the 3D codes on our excluded guidelines if not medically necessary. We have options.
See, but
And if
that's
there
a
was just,
example.
if the diagnostic
What kind of
bucket got
diagnostic
collapsed.
test?
Yeah. I hear the point and I will think about it and we can get back to you. So if you guys all want to approve the breast one, it will have one modification, and then I've got some notes about our discussion. Any other discussion about breast issues? We have, I think we can actually, you guys are doing amazing. I wanted, well, we had Brian who just left, to do
GI
urology.
and then urology.
Let's do GI and then we'll do urology. So, gastroenterology, there were a whole bunch of lines. There were really no procedures, but a lot of these diagnoses, or there are some diagnoses. There are a few procedures. Most of them you'll see in, I can't remember where you see them, but there are a few. But the thing I'm really flagging for discussion is that we have some diagnoses that are currently non-funded, which means they wouldn't, you could have a hard stop on a PA criteria, for example, you know, for constipation, there's some very expensive newer medications, and the pharmacy could just say it's an unfunded diagnosis. They won't be able to say that anymore, but they can say you need to try 5 other things first or something like that. So one of the new paradigms is that we cannot say a diagnosis is not medically necessary. All diagnoses have to be at least medical management. If that makes sense.
So there could be some drug costs associated
Right.
with medication. for these
Exactly,
conditions,
and
but
the
we can't
three
talk
that-
about those here.
Right, the three that kind of pulled out and I flagged for our pharmacy colleagues is irritable bowel syndrome, constipation, and small intestinal bacterial overgrowth. There's tests and treatments for those. Gastroparesis, we currently cover it only if it's caused by like diabetes, not if it's idiopathic. That doesn't make sense. So I'm condensing them down into like, if you've got gastroparesis, you can cover with the current guideline. And then there are benign neoplasms of the GI tract, and there were surgeries. I'm moving them to covered lines that have the appropriate surgeries. These things appear to only need surgery if they're causing obstruction, pain, you need to clarify the diagnoses, and I didn't think a guideline would necessarily be needed. Most people don't want a benign something, they don't want major surgery to take it out. Everything is gonna end up just being medical management. So there's gonna be a lot of things going in the medical management line. There will be a new line called benign neoplasms of the digestive tract. It's gonna kind of take everything from what's our current line 631. And there's endoscopies and open surgeries paired. And again, this would hopefully be things that you would either not want, you want to know what it is, or it's doing something bad and you need to fix it. And then there's a guideline that needs to be deleted, and then collapsing everything that all conditions that lead to gastroparesis will be put together. And there's the current the gastric electrical stimulation guideline will be continued. So we're gonna have diabetic and idiopathic gastroparesis will be together. They'll be paired with gastric electrical stimulation with a guideline. So we don't need guideline note 207 anymore because this is, we're not gonna have an uncovered, we're not gonna cover things and not cover things. Our gastric electrical stimulation will say that we cover it if you meet the current criteria. You don't have to have the 2 diagnoses we cover it for now. It'll be all 3 of the kind of classes. And then cyclical vomiting and migraine, I'm moving to the migraine headache line because they need some of the same migraine medications. There is a couple of things that were looked at in the food allergies kind of area. They'll be put into the food allergy line. There's hourglass stricture of the stomach that actually needs endoscopic dilation, so I'm putting it on a line where that is. And then gastric intestinal neoplasia needs endoscopy and biopsy, so I'm putting that with the GERD line. which will become a code group. So pretty much everything's gonna stay the same. There'll be coverage that will be new for, I think it was, let me see, for gastroparesis, which is just K 31.84. It will join its buddies, the other gastroparesis diagnoses with the same guideline. Questions? Anything wants to flag for me?
I think we should look into guideline notes for IBS and SIBO. That was one of the questions, right?
What kind of guideline note do you want?
Probably diagnostic criteria and appropriate treatment. And then step therapy stuff for constipation and all those is gonna be P&T, right?
So some of this overlaps with PNT, but I can talk to them in a minute.
I would-
So we can only write, sort of the way things are going forward, we can only write a guideline if we want medical stuff first or medical stuff as part of it. So if we only want,
Versus what?
so like
Versus drugs.
constipation, if we wanted to say that you need to have timed voiding, trying to think of something else, for some of the dermatologic, we say that part of the criteria is you need to try light therapy.
Yeah.
We put that in the guideline because they
Yep.
don't have any control over light therapy.
Yep.
But if it's all drug related, PNT comes up with what's the appropriate diagnostic criteria. We can't say like drugs are only available if you meet.
Diagnostic criteria, not step therapy. So they'll say, this is what you need to have a diagnosis of IBS or SIBO. And that'd be us.
There was one that that I just looked at. It's escaping
I get
me.
them doing like step therapy and stuff, but them putting diagnostic criteria that's a medical decision, not a pharmacological decision.
Like the REM light sleep disorder thing, like P&T took that, the 24-hour like circadian rhythm disorder, right? But like insomnia, since there's like CBT and medication management, we took that.
Or we shared it with them. So if you are worried about drugs only, what kind of a,
I think I'm, on one of them, I'm concerned about, I think we need to talk about the diagnosis and how definitive it is / what criteria do you use? I think the other as
Diagnose the
well.
condition outside of office.
because we're gonna be talking about EDS later, Ehlers-Danlos syndrome, and we do require them to be
Right.
diagnosed by a certain criteria, but that's to get services.
Yeah, I'm thinking for both of those.
Okay,
I think there's debate about the SIBO diagnosis in general, and I think IBS is often not diagnosed with rigorous criteria. It's kind of, you have,
Maybe that just needs a diagnostic guideline, then.
yeah.
That's it.
or work with PNT,
I know, like.
Right,
Abroad, you know.
okay, so I hear you with that, Max, I'm flagging that. For today's vote, it will just be putting them on
Yeah.
the medical management line. And then I will work with PNT and internally with other staff to see what kind of a guideline we might write for irritable bowel constipation and SIBO.
I guess I might have a question, but you can see go on. Because there is a question about the diagnosis. It's not
So-
generally accepted in all circles, right?
We don't have the choice to not cover a diagnosis.
Oh, if there's an ICD code,
Yes,
just equals.
yes.
Equals office
Okay.
visit.
So they would get
Then
the
I think
office
putting some
visit.
But we could put in, depending on our discussion with PNT, we could say medications to treat SIBO are only available if the SIBO is diagnosed.
with this
Yeah.
criteria.
The international guideline, blah, blah, published in 2017,
Yeah.
which would require a X test to be positive by more than 50%.
Ariel,
I'm making that up.
wouldn't that be a
totally.
PNT?
I think that's PNT, but I will look at it and talk to PNT.
Indications for that drug.
Yeah.
Drugs are
Make a
antibiotics.
PNT, is there a large amount of medical practice involved?
Yes,
Okay.
there's quite a few doctors, and a lot of their PA criteria are things like, does this patient have a X result or, on such and such a test? They do, that's probably a pharmacy guideline, but I
Yeah, it
flagged it.
might be, I don't think we've had these discussions that overlap, okay.
So, what you would approve would be the basic changes here.
Yeah.
I will take back your input and work with you.
Figure out who's got this, okay, thanks.
Yeah, and part of it is that HERC is strictly out of the drug business. Unless there's
Right,
a
yeah, I
medical
don't
thing
think
that
I
needs to be involved.
Appreciate that also meant sometimes it's diagnostic criteria and such, okay.
Yeah,
If the
that's,
treatment is just drugs.
that's one of the big changes that's happening, is that medications can currently be denied because it's not for a funded diagnosis, and that is going away. There has to be another reason.
Right, yeah, I think that part.
But PMT could say, SIBO must be diagnosed really strictly, or they
Right.
could say, there's no generally accepted criteria for SIBO, and therefore it's not an appropriate, I don't know what.
They couldn't do that.
I will discuss this with PMT. I hear your
Right,
concern.
right,
got it.
beverage with the
Got it.
opposite, not exactly.
Oh, medical.
They have a little different legal
Yeah,
framework than we do.
Is this approved as presented, I think?
Okay.
I've not seen any
Yes, it's
modifications
approved
that
as
we had.
presented, because the question is above and beyond what's on here.
Yeah.
Oh, shoot, I forgot to put my meeting note, no, sorry, oh, well, I remember. Okay,
Brian's
And
still gone. so
Brian's
you're
still
on.
gone.
What do you want to do?
Let's talk about urology, mainly because I actually ran a lot of starting by him.
Okay.
And I work with a couple of urologists. So there are multiple things, that are either significant or I thought we should discuss them. I think we should continue non-coverage of spermatocele treatment, but the urologist I consulted wanted. So I ended up consulting with two groups of urologists. The first group was from OHSU and they're subspecialists, and they have a very enriched pool of patients with certain conditions. And then I actually reached out and talked to a couple of community urologists who are just more general practice. The general practice urologist said, no, you don't need to cover spermatoceles. And the specialist said yes. So I think it's one of those cases where if it gets to the point where it's beyond a community urologist's comfort level, it could be an exception.
Is there enough that we need a guideline? Those are cases that we do that, right?
I am just currently doing no coverage until somebody splits us.
Okay.
And then I make them work with.
Yep.
The specialist wanted some changes to the penile anomaly fixing guideline. We currently only cover them if they're a result of surgery. And they brought up some diseases that would result in the same thing, and they thought it was kind of unfair, and I kind of agreed with them. You know, if you have a disease process that results in something versus a surgical thing that resulted in it, and they can fix it the same way.
Why did we originally differentiate those? Or did we just not think of it?
I think we just didn't think of it.
Okay.
And most of that guideline was written with a pediatric urologist in mind. And a lot of these other conditions happen in
Same time,
adulthood.
yep.
But essentially, and then in the penile anomaly guideline, the urology experts really wanted pain with erection as an indication because erections are involuntary. We've talked about this in the past at HERC, and HERC has not wanted to, so I'm continuing that. We can consider their input though. And then they wanted, all the urologists wanted us to make some changes to our benign urinary tract lesion guidelines, which I thought were very sensible. And then continue non-coverage of penile implants for erectile dysfunction, even though the urologist really thought it should be covered after procedures for prostate cancer. However, it's a high volume procedure. It's already covered by Medicare, which is where the vast majority of those would be. I can look into this further if desired, but we do run into issues for treatment of sexual dysfunction with.
Well, so the federal law bans medication Viagra, Cialis. It does not ban the pumps. And so the question for you all is, should those be considered medically necessary according to those criteria we looked at earlier at the beginning? Or are those solely for convenience or for appearance or something else that would fall outside of that medical necessity definition?
Some consistent thinking for the penile anomalies, we said the cause doesn't matter. Right? We're saying surgery, it doesn't matter where you get those anomalies from
But
surgery.
you have to have pretty significant like curvature over like 70 degrees or something like that.
Right, but why, if we decided to cover penile implants, why would we only cover them after cancer surgery versus? Because the other one, we're saying the outcome matters, doesn't mean it matter what cost it, and this one, we're saying it doesn't matter what cost it.
Well, no, I'm saying it doesn't matter.
I know,
We're not
but
covering
that would be my
it.
question if we were gonna cover it.
Yeah, so if we decide to cover it post prostate cancer surgery, then we would have to go down that route.
Yeah, to me, that would be an even
Okay.
bigger question.
Right, and my recommendation is to continue non-coverage. I just flagged that as something that I
Right.
didn't agree with the experts.
Okay.
And then there's a whole bunch of stuff that's just gonna become evaluation and medical management. There were some non-funded diagnoses that were mentioned in guidelines. So I moved them to where the guideline, the funded line that the guideline appeared in. And then there's a bunch of formatting changes. So this one was a really big lumper. So a lot of urologic surgery we have all over the place in all kinds of ways. And the urologist I talked to could not understand why. So it's basically collapsing about 12 lines together that all need the same procedures. This does not include urologic cancer and lower urinary tract symptom. Those are, we think they need to be, these are all the other things, whether you need you have reflux or a stone or something else or hypospadia, like you might need the same procedure on your ureter. So just kind of simplifying things, except cancer, because there's a lot more treatments on the cancer line. And LUTS, because there's a whole bunch of very specific procedures and guidelines for that. So those will remain outside of global urology world.
And things that we don't cover. Particularly for
There's a lot of stuff we don't cover on the LUTS line, or we call out that we don't cover it on the LUTS line. Hydroseals are currently in the complicated hernia hydroseal guideline. And
Is there a separate hydrosol too?
I think I made a separate hydroseal. Oh my gosh, I'm blanking a little bit.
Yeah.
Right.
Redundant pupus, that's the whole circumcision that I know we've had multiple discussions about. That is gonna be outside of the benefit package. OHA has determined it is social, cultural benefit, and therefore it is outside of the benefit package.
Well, I would actually phrase that slightly different. It's the same point. You all determined that it was not a medically necessary treatment unless specific
Yes,
criteria
yes.
were met. In other cases, it is therefore not medically necessary and being done for other reasons, so. And if the service is not medically necessary, then it can't be covered under Medicaid, can't receive federal dollars. So that's the chain of argument. It doesn't mean it's not important, but
So you're talking about guideline note 180 and 72?
Okay, let's
There's
start
two
looking at
guidelines.
them.
Okay.
So hydrocele repair will remain medically necessary for children, 18 and younger, and it's only medically necessary over the age of 18 with pain and functional limitations. That's our current guideline. Congenital urologic conditions, treatment is only medically necessary in children up to at age 18 and younger. We're taking duplication of ureter out of there because that apparently does need treatment in certain adult circumstances, and I don't think it's out of the range of it's not overused. Not many people have duplicated ureters. Penile anomalies, we are going to make the change, essentially no change other than, saying that we're taking out the result of a prior penile procedure. So if you have, hypospadias, documented urinary retention, all of those things, it doesn't matter if it's from a procedure or if it's from a disease, we'll cover it if you meet those criteria.
So you just wrap the two, because there's a, like, guideline note, is that 180?
Because that's 73.
Okay, so then there's another one that talks about,
180 medically indicated circumcision. That's separate because we're not.
okay,
So these are the surgeries for like release of a chordae or for, I don't know, whatever else they do for fixing things that are not right in the fetus. But it's not a circumcision. Circumcision is still gonna be its own guideline.
okay, but it says right there, circumcision is medically necessary only for patients with.
Right, that's guideline note 180.
Right?
I'm talking about guideline note 73, which is penile anomalies. Which has,
Well, on that, currently, the code for routine and ritual circumcision as a Z code only leads you to guideline note 73. Currently.
it will be excluded as cultural.
So, yeah,
Z41.2.
so routine, so that code will be put into an exclude, the condition will be put into.
So
Okay.
let's differentiate here. So currently, we just made last time, we had guideline 172, 173, those essentially we put on the excluded file. We changed those to an excluded services guideline. In 2027, we're gonna need to bifurcate that into not medically necessary, you know, unproven or whatever, and
Outside the benefit
excluded
package.
outside the benefit package. And so if there's a diagnosis for routine circumcision,
There is.
that is
There is.
outside the benefit package, whereas, if, you know, some treatment is never medically necessary because it's unproven, that will be not medically necessary.
So
So
I
in many
have-
cases, we're lumping things, in this case, we're gonna be bifurcating, and they would get a different denial reason on the denial notice. Accordingly, in the future state.
And I just made a note that we, to differentiate that it'll be the Z41.2 encounter for routine and ritual male circumcision. It will be outside of the benefit package.
Okay, thank you.
So they would have to have whatever other diagnoses we have. The
Listed there, yeah.
balanitis, erotica, obliterans,
Right, yeah.
those kind of things.
Okay, penile anomaly.
So we have a penile anomaly
Right,
that's
right.
non-circumcision. And then we have a circumcision.
I have a question just about penile anomaly.
Of course,
not
yes.
circumcision. You can have a buried penis from obesity.
Yes.
So does that mean somebody can have
Do you want to take that one out?
liposuction for a buried penis? Because if I read that, I would say it does.
I can look into whether we want to delete that from the guideline.
I mean, that's just the one I thought.
Brian, are you tracking us?
Oh, yes.
Yeah, sorry, I'm back. I had to respond to a call. So,
No worries.
oh yeah, just came back. So I heard the discussion about a buried penis.
So yeah,
Yeah.
guideline note 73, under the second part there, results in a buried penis. What happens when the buried penis is a result of significant obesity and nothing else?
We
Would
very,
that guideline cover treatment for that scenario? Because I would read it as
Surgical
yes.
treatment.
I mean, I can say we very rarely do anything.
Yes, that would be weird.
Yeah, I've not heard of like, liposuction for this or anything like that. I mean, obviously we,
I've had at least one request for it.
Well, right,
Yeah,
I'm worried that that would allow it. So the change was we previously had it as these conditions had to be as a result of surgery, but there are some adult acquired conditions that can cause it instead, so we took away that requirement. So I'm thinking of that one exception. Can you think of any other exceptions that changing that would have us
Brian,
possibly
would you
cover?
be
things we don't
okay if we
intend?
put buried penis, just for evaluation, so the urologist can evaluate, but no surgeries?
yeah, that I
Okay.
would.
Well,
I'm sort of
Wait a
worried there
minute.
might be some other exceptions on there.
So this
too.
guideline applies to the urologic surgery line, which would not have liposuction on it. So liposuction wouldn't even pair with these conditions.
I think it sounds like what I'm hearing is that buried penis doesn't need anything but a medical visit, so I can take that diagnosis, put it on the medical visit only line and strike it from this guideline. And that would be okay with the other urologist didn't say anything about it.
Urologist.
Yeah.
Okay. Med management only, no surgery, strike from guideline.
Yeah, I
That is,
support
yeah, that's good, because when patients see that they have a surgical benefit first time diagnosis that they carry, they kind of like surgeries, they're right, and they're really demanding about it, so I think that's good to.
Okay. Perfect. So I will make those changes. Some of this, like something like this where you've all agreed and I just have to do some stuff, I might just bring it back as a consent where you're just gonna see it and say yes. Benign neoplasm of the urinary tract, they actually wanted me to add a criteria. They wanted symptomatic pain refractory to over-the-counter medications. They don't want it to just be bleeding or urinary obstruction, like all the urologists wanted that.
It's not urinary obstruction?
Oh, I'm sorry. So actually, it does broaden it a little. So
Okay.
bleeding or
okay.
urinary obstruction, or if it's really painful and you've tried over-the-counter medicines. Because they just didn't want people to end up needing lots of pain meds and things like that, so. And then, there was some debate about the whole oncocytoma, like how many centimeters, this and that, and the final decision by the group was keep it. Don't worry about it. The obstructive and reflux neuropathy just remains the same guideline, except for pediatric population, I defined as 18 and younger. Sclerotherapy, same, and then medically indicated circumstances.
Just flagging that one, Ariel, 18 in your, that's for clinical reasons, not
Yes.
PTSD.
And then medically indicated circumcision will remain.
I'm sorry, go back up to the one that says children.
Yes, but
Because
do you
it-
want it to be 21?
It needs to be aged 21 and younger, please.
Aged 20, I think at 21 is when the.
Yes, it's
So age
20 and young.
20, yes, 20 and younger, or
I
under
think we
20.
said underage 21 is what we tie it to the birthday. Yeah.
Wait, you want that because of EPSDT reasons? I thought we just said, oh, clinical.
Yeah, I thought that you just said it was a clinical reason. Is there a
I don't
physiologic
know.
difference between 18 and 20?
In my opinion, you'll just hang us out to dry.
We will, and I think I remember seeing that in a guideline that we talked about a little while ago. I will make sure wherever guidelines have under 18 that I will double check and make sure that that's clinical, otherwise I'll change it to 21.
Let's say, so
Yeah.
if HERC says something is not medically necessary above the age of whatever, 14, 16, 18, HERC can do that, and that can be referenced in the UPSBT review.
Okay.
That is different than what happens with the prioritized list at age 21, where HERC says it's not covered, it's
Like,
excluded.
I think the one I'm thinking of is inguinal hernias, and the
Yeah.
evidence is 18 is the cutoff because of the studies.
Yeah, if the evidence is 18,
So-
use 18.
Can we
Yeah,
note
okay.
that in those though? We picked 18 because, say it's based on the studies or whatever.
Yes.
Because I am still cautious if the judges will accept our guideline notes, even if they're written for data, because DPST means that still.
Okay, so put it in all those cases, then you'd like some kind of annotation that this age was selected for clinical reasons, like
Yes.
spell that out.
Yeah, I'd say like it is
Yes.
based on this recommendation that there's no benefit of that, which we did in one of the tongue tie ones or something, I think we wrote it that way. That's the
Yeah.
reason.
So if there's an age limit, like for example, like 18, we're saying that it is through age 17, right? So when the
Right.
patient
Yeah.
turns 18, okay.
I think we're trying to say under age X or age X and over.
Got it. So under probably is more clear, right? Because.
Under, right, so
So-
we changed to under age
Her
21.
staff will make sure, we will go back through at some point and look at all of our guidelines, and if anything doesn't have 21 as the cutoff, we will look and see if there's a clinical or, literature reason and annotate it.
Yeah.
And if there isn't, we will change it to 21.
So that's
Or-
a big,
Yeah.
long, straightforward item.
We have some spare time to do that.
Good. Oh, who's here? Perfect, thank you. Okay, so we have changed guideline note 138, just that slight modification. I would suggest that we approve everything, and I have a couple flags that I'll bring back as a consent, and one is the buried penis issue, or it'll be a whole other topic, depending on what I talk about it.
On the benign neoplasm part, because we are expanding coverage, like how frequent is it that people are symptomatic refractory to pain medications?
Apparently very.
I know, so I'm wondering what that impact would be. Because I don't think we
That
take that
is
much.
consistent with our hernia guideline.
Hernia's function or impacts work. It's not, can't be controlled with over-the-counter pain medication.
Okay, do we not want to include that? I mean, that was what they suggested, that's not our current guideline.
Yeah,
Kind of our status quo is keeping current guideline.
I'd be concerned that there's a lot of other conditions that we don't put that modifier on. And I'm wondering why this one would be.
Then we will strike that wording. And it will stay essentially the same, except for the.
And I'm happy to have the discussion because this could be different, but I mean, there's a lot of conditions that we.
There's a lot of things I said no to the urologist about. so.
Yeah, and there'd be a lot of things that we would cover if we added that caveat to them.
Okay.
I think we
That's
need
not
some
consistent
evidence
with
or
previous
discussion
decisions,
there.
is a very good reason.
Because we again still have the exceptions process, and if it's that common, then we write a guideline note to say it's gotta be impacting function or, making it consistent.
And
with the other
bleeding and
ones.
urinary obstruction sound like good reasons.
Yes, when you first said that, I was like, we don't cover it for your name, we should. Yeah, yes, those are functional reasons.
Perfect.
Yeah.
Great. You guys are rock stars. You
Okay,
do
so the only
everything
thing-
but ophthalmology,
Right,
and
okay.
ophthalmology is a big ole rabbit hole.
Okay,
Unless you're an ophthalmologist, in which case it's probably super exciting. So we have a few that are approval as written, most are approval as modified.
Right.
With a few things that I have promised to bring back individually, to a future meeting.
Chris, do you have a quick question?
Yeah, it's just a tiny thing, like for Q 54.9 hydrosphagia is in your list, you have unspecified code group. Will those change
That
back
is
to
going
just
to be
the
medical
evaluation and medical
management.
management? Sweet.
Yes,
Okay,
thank you for
thanks.
calling that out. I am changing everything that I have said that's not, medical management is the default for everything, unless there's a really good reason that I don't want it there.
Great, thank you.
Thanks
So
for
I'm
calling that
looking
out.
for a motion to approve with noted modifications to the key issues A through K, with the exception of H, which is held over for another meeting.
So are we holding it?
Motion to approve.
No, we have Ehlers-Danlos and fibromyalgia starting now.
Okay, so, thank you. Katie moved, I believe that
I'll second.
Brian
Brian
seconded.
seconded, so now Daphne, please roll call for
Was H off though?
Great, no
With
problem.
H is table.
Right, but you said H, I just wanted.
H is
H is
also
table.
I know what I'm
table.
voting on. Okay, perfect.
Antoinette Awachi,
Yes.
Brian Duty,
Yes.
Mary Angre,
Great.
Holly Jo Hodges,
Yes.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
Sarah Love,
yes.
Chris Benzon,
Yes.
Katie Shable,
Yes.
and note for the record that Lucy Langer has stepped away for about half an hour. So she has no vote. Motion passes.
Thank you. All right, we'll move to previous discussion items.
Do you want me to distribute the food now, or do you want to wait till after this item? It's sort of a little early, so.
Trigger.
Y'all hungry?
Yes.
I'm sorry, let's eat then. Great idea. Let's break for lunch for 2 seconds.
So I had a friendly suggestion from our own Max Kaiser that because Ehlers-Danlos syndrome and fibromyalgia have a lot of kind of overlapping discussion points and recommendations, that I do both issue summaries, kind of bring up the topics. We have testimony that we are that people have signed up to give. We will listen to the public testimony for both EDS and fibromyalgia. and then we'll discuss and make a decision. Is that acceptable to you all?
You're gonna present, then testimony, then.
Yeah, but it's gonna be fibromyalgia and EDS. We're not gonna treat, we're gonna, because there's a lot of overlap, we wanna make sure we're consistent between the groups. Is that acceptable? Okay, and.
Did I miss trigger point?
We're skipping trigger point for right
Okay,
now.
Perfect, thanks.
Because we have folks that want to talk to us about, do we have folks here for testimony already, or are we still waiting?
We actually don't have anyone online. I don't know about in person.
We don't have any in person, okay. So we may or may not have public, we have people sign up and we had written testimony that was in your packet. So, coming on the agenda first, we'll give that one, give Dan those, you'll remember we've had some previous discussions. We had a couple of experts come to our October meeting. And.
Sorry, you wanna give us 5 minutes to get everything open? No.
5 minutes to get everything open, does that mean I get to eat?
You should, everybody, get open everything, make all of our. All at once.
Okay, you'll go on mute for a moment.
Crunch, 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 because it's.
I am so proud of you guys, we got so far. All right, welcome back.
All right, online, here we go.
So I'm gonna start off with Ehlers-Danlos syndrome. I'm just reminding you all that we had some significant discussions about this in the in the fall with providers coming and talking to us. And just to remind you all, the current evidence-based literature for interventions for EDS is limited in size and quality. There's insufficient research exploring the clinical features of interventions, and clinical decision-making is currently based on limited research evidence. The only treatment guideline for EDS, there is one international guideline. There was some concerns raised about it by our experts when they came. There are multiple different types of EDS, hypermobile being the most common. There's vascular and other forms. The forms that involve vasculature may need some cardiac things. There is some genetic testing. It only finds some subtypes. It doesn't find the major subtype, or at least we have not identified the gene yet that's associated with the major subtype. In practice, it's treated with physical therapy, counseling, and office visits, and perhaps splints or other supportive care for things like joint instability. We discussed this. There was concern about adding it to a covered line, mainly because there's still some questions about the criteria to diagnose it, as well as some concerns about treatments. There was 2 listening sessions where we heard quite a few things from patients, with 63 written comments after that, and they were requesting consideration for some specific services, including physical therapy, durable medical equipment, medications, and then dental issues, because EDS folks have issues with teeth. And they also wanted more awareness and acknowledgement by the medical community. The expert guidelines, there's a expert guideline written by Sully et al. In 2017 that is the most accepted clinical practice guideline. And they do acknowledge that there is quite a few gaps in the literature. For this review, based on the public feedback, we had multiple, 16 references that were submitted. One, Ehlers 2022 was a systematic review of exercise and rehabilitation for patients with Ehlers-Danlos, with 10 studies with 330 patients. All of them did have EDS as defined by the 2017 EDS classifications. 5 were RCT, 2 high quality, 2 fair, and 1 poor. 5 were non-RCTs, 4 were critical risk of bias, 1 at moderate risk. The studies showed some improvement with physical therapy after the intervention period, and 1 adverse event, which was non-serious, was reported. So the conclusion of the authors was that this highlights the potential value of exercise and rehabilitation for patients with EDS, but it also showed that the literature is very, that there is a dearth of RCTs and high quality studies in this field. And they had a lot of suggestions for how future studies should be done. And claims review, we found physical therapy, actually, what did we discussed medications, PNT are not saying requested medications, but there were some with an EDS diagnosis who did get denied claims for stimulant, proton pump inhibitor, allergy medication, and acne medication. There are some similar diagnoses like Louis-Dietz syndrome, which is a subset of Ehlers-Danlos that has a genetic test and it has aortic root dilation as a major complication. Marfan syndrome, which is a different genetic syndrome. It also has cardiovascular manifestations. Those are on the dysfunction lines. And Marfan's also has a definitive genetic test. We did get public comment on EDS. There were 6 different public commenters. They all spoke on the importance of recognizing Ehlers-Danlos as a condition and allowing appropriate care for patients with this diagnosis. The one request that several made was to physical therapy as a way to prevent complications by strengthening the muscles. So that just make you aware of the public comment that we received, and that was in your packet if you wanted to read the comments in more detail.
There were additional ones sent by email.
Yes, and additional ones that were in your final packet that you should have
On the
gotten an email
webpage.
to. So in summary, Ehlers-Danlos is a genetic syndrome. There's no actual treatment for the underlying disease. There are a number of small studies of varied quality that show mixed results for treatment of Ehlers-Danlos with physical therapy or cognitive behavioral therapy. And staff had determined that the evidence is insufficient to draw conclusions about whether either of these treatments is effective. There are complications of Ehlers-Danlos, such as joint dislocations, that do have evidence that PT is beneficial. And this treatment should currently be covered under those diagnoses. If you have, for example, knee dislocation, you would get treatment appropriate for the diagnosis of knee dislocation. We did get expert input and patient and caregiver input stressing the importance of covering EDS on a covered line for patient validation, as well as PT for strengthening muscles to prevent injury and for provider education. They also felt that there should be DME such as wheelchairs as well as medications should be covered for EDS. Most of the common medications prescribed for this condition are not prior authorized because they're prescribed for symptoms rather than the condition themselves. Essentially, the staff recommendation is to move this to a covered line. The medications are currently not being controlled. If you had a disability that would make a splint or a wheelchair or other thing would be appropriate according to the DME rules, those would be available to you. The other types of services like PTOT, chiropractic manipulation, oxygen therapy, etc., don't have evidence that they are beneficial. With the caveat that PT would be beneficial for a specific injury or sequelae. So the staff recommendation remains to move the ICD-10 code for Ehlers-Danlos to the line for lupus and other connective tissue disorders, removed from the uncovered line. This would have hearing only with medical management. And so in the future, this would be in the medical management only grouping. There would be a new guideline for Ehlers-Danlos syndrome that would say it's included on this line if you have a known genetic marker or you otherwise meet the criteria of the 2017 International Expert Guideline. The diagnostic testing, including genetic testing and diagnostic echocardiograms, are covered when medically necessary to make a diagnosis. There is no effective treatment for Ehlers-Danlos syndrome. However, this condition may result in multiple manifestations, including joint sprains, strains, and dislocations, and cardiovascular problems, which treatment should be covered when medically necessary and appropriate for the patient based on the totality of their clinical condition. Patients with suspected vascular EDS should be monitored with echocardiograms if they meet the 2017 diagnostic criteria no more than once per year unless symptomatic or having known cardiovascular. Because of frequent comorbidities and multiple manifestations of EDS, providers and plans should carefully monitor interactions with prescribed treatments to avoid contraindications and harms. For EDS patients who also have chronic pain, see also in Statement of Intent 5, treatment of chronic pain.
Well done, yeah.
We're talking about that guideline now, aren't they? Later, right?
I can't hear you, Matt.
No, I think we had a discussion on this, but we want.
So Statement of Intent 5 is essentially people with chronic pain should have multidisciplinary management.
Yeah.
It can be the exact wording. It's
No, I don't quite about that part.
I think more discussion going to hear testimony.
Yeah.
Which we now have.
So we do testimony
Which I think-
now
I
and
think
then.
people have logged on.
Oh.
I see Chris and I think I've heard Mary have, do you just have clarifying, I just want to do clarifying questions right now.
This is Chris. I don't know if it's clarifying,
I'm
but
sorry,
I
Mary,
just think
Chris
this is, oh, sorry.
Go ahead, Chris.
Go ahead,
No,
Mary.
go ahead, Chris.
Oh.
Mary will be second.
I just think this is much better, clear presentation. And I think my only clarifying question is like, I see the language here has the line 141. So that would then just move into a code group that you had listed when we make the switch to the systemic lupus and other diffuse disease connections.
Yes, yes.
Okay, but I think this addresses both the concerns that I saw in the comments and clarifies for PTOT that we had heard we're getting denied claims. So the guideline note would kind of, and the language that you've used behind there is perfect. And I feel like aligns with the way we've done things. So thank you.
Thank you. Mary, did you have a comment? Or a question?
I have a question. Are we going to have other specialists such as neurologists speak to this diagnosis?
I reached out to neurology, rheumatology, and I think one other specialty, and all of them told me that they do not treat this condition and didn't want to be on the record with any comments.
Thank you.
All right, and now I know we have public testimony for Ehlers-Danlos, and I don't, if you missed the first part of what I was talking about, I am going to present information on Ehlers-Danlos and fibromyalgia together, just because I know there's some folks who want to speak to both. And then we'll take public comments on either of those topics, and then there'll be further discussion by this group.
Thank you, this is Daphne. So I think we had said we were taking public comment a little bit later, so we might not have everybody here right now. And I'd like to, I think there's a little bit of misunderstanding about who is supposed to be giving verbal testimony. So I'd like to do something a little bit different this time and ask people, if you did sign up for verbal comment, to raise your hand or talk to me in Q&A, and we'll get you signed up. I don't want anybody left out. Thank you.
Yeah, and for those who are already here who want to give verbal comment, if you're here for Ehlers-Danlos, just indulge us and listen to the fibromyalgia, and then we will allow public comment on either or both. If anyone arrives late who's already signed up for public comment, we will stop our discussion and hear their public comment and then come back to our discussion and make a decision. So fibromyalgia, chronic fatigue syndrome, and chronic pain syndrome were all on the same line. The staff proposal is fibromyalgia needs to be on the evaluation and medical management only code group. There's evidence that there's no benefit from cognitive behavioral therapy or physical therapy for that condition itself. Obviously, if it results in somebody having depression or they have an injury, that obviously would qualify for whatever services would be appropriate. There is a current guideline about fibromyalgia, and staff is recommending, based on public comment, that we delete this guideline because it's a clinical practice guideline. It's not a coverage guideline. We have talked to our PMT colleagues and they agree. Chronic fatigue syndrome is suggested for addition to evaluation and medical management, as no evidence was found for any treatment. Chronic pain syndrome, and just to be clear to everyone, because there was some confusion in the public comment, this is a specific diagnosis. It's not the world. There are so many conditions that result in chronic pain, and the HERC is completely aware that chronic pain is the endpoint of thousands of pathways. There is a ICD-10 code for chronic pain syndrome. We have previously worked with the Pain Commission at OHA, and they strongly feel that psychotherapy codes need to be paired because there's good psychotherapy interventions for chronic pain syndrome. So that is the proposal. And that is just for that ICD-10 code. So if you have fibromyalgia and it's not paired with psychotherapy, but it's resulting in a chronic pain syndrome, then that you could use that other diagnosis code. It's all about our wonky system in the world, in the US. Yes, Mary?
Oh, I didn't have anything, thank you.
Okay, so fibromyalgia has been discussed multiple times. We've done some in-depth reviews. We've looked at it as biennial review change. We had a very lengthy discussion in 2018. And these discussions have all resulted in evidence reviews where no evidence was found for effective treatment, unfortunately, because this is a group of patients that we know is pretty impacted by their disease. And then we've also talked about chronic pain syndrome over the many, many years. Acupuncture has not been found to be successful for it, unfortunately. The Oregon Pain Management Commission does include psychotherapy as an evidence-based modality. It's in their chronic pain their pain management module that all providers are required to take. So all providers in the state are being told that this is appropriate treatment. The staff recommendation is to place chronic pain in conditions benefiting from psychotherapy, and then everything else is essentially going to be in evaluation of medical management only. Treatment of chronic pain, the statement of intent 5 doesn't actually need any changes. It will just appear as current, and the guideline note for fibromyalgia will be deleted. Before we have public comment, is there any just clarifying questions from members? Okay. And I do realize that we may have some latecomers because of some confusion about when public testimony was. Anyone who is currently here, we're happy to hear from you. How many folks are here currently, Daphne?
2.
Okay, so what we normally do, is 3 minutes still sufficient? Okay. So each person will have 3 minutes to speak. We ask that you state your name for the record as well as any group that you represent, and if you don't represent any, that's fine. And then any conflicts of interest that you might have, these are things that are financial, either for you or for a family member, or intellectual, like if it's paper, if this is a condition that you have, a family member has, or that you treat, that's not.
Are we ready?
Yes, I believe so.
Thank you. I'm gonna invite you to talk. Katie Zeno, you're up.
Don't
Thank
need to
you.
read it.
Oh, yeah, we have to read it.
Oh,
to read
that's
the
right.
statement.
I'm very sorry. I'm very rusty. Sorry, Katie. Wait one moment, please. This topic may be a sensitive discussion for some. As a reminder, HERC is a policymaking body and cannot make decisions about coverage or care for individuals. Any policy changes resulting from today's discussion will go into effect at a future date. This discussion may be intensely personal for some, yet in this forum, we tend to discuss subjects in terms that may seem clinical and impersonal. Not every person's experience will fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using HERC's methodology and processes to determine the importance of services. Based on the people signed up today, we're allowing 3 minutes per person to testify. A progress bar will show how much time is remaining. After your allotted time ends, please remain in the meeting for a few minutes in case members have follow-up questions for you. Please begin your testimony by stating your name and any conflicts of interest you have regarding this topic. And Katie Zeno, you're up.
Hi, can you hear me?
I can, thank you.
I don't seem to have access to a camera. Oh,
Make it just verbal if you don't have.
okay, no problem. Okay, my name is Katie Zeno. I am a patient advocate. I don't believe I have any conflicts of interest. Real quick, I do appreciate moving EDS into the covered line. I did want to highlight though that the specialist you had reached out to that said they don't treat EDS, this is an issue that the patients keep running into. I have a neurologist, I have a cardiologist, I have a rheumatologist. The doctors that choose to treat us are few and far between, but they are needed specialties. I did want to add, if you could add a caveat to the to the EDS prioritized list for adding the HEEDS diagnosis for HSD. So if that changes, so the criteria right now is based on the 2017 criteria, and then adding something, or when this criteria is updated for adding hypermobility spectrum disorder. And then also the other quick note was about chronic pain. It says see statement of intent 5 for treatment of chronic pain. A lot of patients with EDS metabolize medications much differently and need different modalities for pain management. And the statement of intent 5 is based on an outdated bias system that a lot of patients have testified at the Pain Commission, including myself, that it is not, it doesn't work. It's not working. So that's definitely something that I wanted to reference. I think those were just the two top things. The other one, I think I sent an email in that a lot of doctors, lump in fibromyalgia into EDS while they're getting the EDS diagnosis. So it's very challenging while you're navigating, dealing with chronic pain and unknown injuries and such. Getting labeled with, chronic pain syndrome or fibromyalgia and such, and then just being referred off to psychotherapy when in fact it is, something else going on. So I appreciate everything. I sent in my comments via email. Thank you very much for your time.
Thank you, and I just wanted to let you know, we have to have a specific document. We can't reference or update, so, but thank you for that comment.
Sorry, can you reference what you're?
Like we are referencing the 2017 EDS diagnostic guidelines. We have to reference a published specific document. It's state rule and law.
Got you. So if the criteria is updated, then that would be something that we would have to come back to the table to add?
Yes, and
Okay.
you can just inform HERC staff, they put an update, bring it to us, we will bring it to the commission.
Okay, perfect. Thank you very much for clarifying that.
Yes, thank you. Is there another person on this topic?
There is. Thank you, Holly Jo. The second person and final person at this point is Amara M. Amara, you have the floor.
Hi, I actually am at a doctor's office, so I didn't expect to talk today, but I just wanted to mention a few things. I sent in my testimony, my written testimony, which was added to the meeting materials, so I appreciate that. As Katie said, I also want to reiterate, and this is Amara M., no conflicts of interest. I'm the founder of the Organ Pain Action Group. I've been doing advocacy for, gosh, I think about 10 years now in Oregon. I have a lot of experience with the EDS community and the pain community. Definitely undertreated and undercared for populations in Oregon. It's very hard to find specialists here, even just basic care. But I also wanted to mention and emphasize how important it is, and I did this in my listening session way back over the summer, I believe. EDS and HSD should be equal. Absolutely, HSD is just as debilitating as EDS. I'm not really sure why HSD has not been included, but when I did my listening session, I included both and explained that both were equally important for care, and also possibly adding to the prioritized list. I also wanted to share what Katie was saying about the 2017 international criteria. That's good to know that that could be easily updated, because if you go to the EDS International page, that's in the works now is updating the criteria, and it should be in 2026, I believe, coming out. So that's right around the corner. And then also the statement of intent, the Pain Commission, which I attended, I think almost every meeting. I mean, maybe half to 75% of their meetings in the last few years. There has been a big shift and update changing with their pain education module. There's actually, the draft is online right now. So it's going to be quite different than the last pain education module. I just putting it out there if anyone's curious to take a look at that. The one thing that has been kind of an issue is this pain science. Not everybody agrees, that that's the way to go. I mean, there's different narratives on how to treat pain. That's one, and that's fine. Just wanted to put that out there too. Thank you very much. I really appreciate you guys doing this.
This is Ariel Smith. So hypermobile syndrome disorder doesn't, as far as I know, have an ICD-10 code. Oh, it does. What's the M35? M35.7?
We actually looked at this together, and there's conflicting resources on it. So I think we should take hypermobility, non-EDS, bring that back for clarification.
Yeah.
Because there's a couple different, there's not one that says hypermobility syndrome.
Yeah.
There is the ICD-10, it's 15, 20 years old, and so it doesn't match the current understanding.
Yeah, if I remember correctly, we looked this code up, and it was for people who have hypermobile joints that are not causing problems. Oh, hypermobile EDS is one of the codes we're moving.
There's hypermobile EDS, but then there's people who don't meet the EDS
It's like
criteria.
hypermobile joint syndrome.
Hypermobility syndrome.
Yeah, and when we looked into the coding references, they were basically just saying your joints are looser than normal, but you don't meet any other criteria.
Right. An M code would fall into this fine.
Yeah, so the hypermobile EDS is one of the codes that we are.
But it's not the M code, there's an M
That's
code.
hypermobile, yes, right?
Okay.
That's different than the hypermobility syndrome.
Yeah, so we need to bring that issue back. Let's focus today
Outside of the
on the
global-
Q 79.6.
Yes.
And we'll bring that other item back.
Okay, did you want to present this now, the next, so we have no more speakers, correct?
Correct.
Thank you. And now, you're gonna move to, are you gonna go back to trigger point, or are we gonna move?
We need to make a decision, so it's kind of a dual decision. The EDS would be moving the 5 codes that you see here.
Okay, so hang on,
To a
pay
covered
attention
line.
with this here.
To a covered line with the new proposed guideline. Staff will research the M code that was brought up and bring that back as a separate item later. So that would be your decision on EDS. Your decision on fibromyalgia is a benefit update, so sorry, we're switching kind of the lens. And it would basically put the current group that is paired with psychotherapy, we would only continue to do the chronic pain syndrome with psychotherapy, and everything else would be in the medical management group.
Okay, so right now, we just talked about EDS, and that's what's on the table. Yes.
And then we talked about fibromyalgia, we can do EDS individually if you would like.
I'd like to do it individually. So discussion, questions on the EDS information just presented
And the staff recommendation.
and the staff recommendations. Feel free
This
to
is Chris.
offer
I
a
have a
motion to
question.
approve.
Oh.
Oh, go ahead.
It's more, I know where it's going for us, like for the evaluation and medical management. And we had talked about how it falls, like what the next steps are for the other pieces. And we're not part of the drug world. And so then the piece that piece of whatever might fall after the medication, the evaluation and medical management would go to the P&T committee, correct? If there's like specific medications that are being requested for this condition.
Correct.
Right,
And-
so
Okay,
each
thank you.
medication class will have its own PA criteria, preferred agents by CCOs, and that's taken care of by the pharmacy and therapeutics committees.
Perfect. Thank you.
And there may be edits, like if 2 medications are requested that have significant interactions, there may be a stop by pharmacy until they can clarify.
But that's nothing new. That's business as usual, the way all medications are managed. So that's not changing anything.
The only thing that will change in 2027 is currently if a medication were requested and the diagnosis were one of these EDS diagnoses that can be denied for below the line, that won't be able to happen anymore after 2027. But, and that will no longer happen if you make this change.
This change is actually proposed for
October. Right, so that will also change as a result of this decision that you're making today.
And why is it that this is an October change and not a 1/1/27 change?
This came to us in the course of ordinary business. We would have had to look at it anyway with 2027.
Okay.
So
it came to a different mechanism.
Yeah, exactly.
Got it, okay.
right, there was this came through our normal business. We need to address the topic. You could decide to approve the staff proposal, to change it, to not do it. But, the equivalent will need to happen in 2027 with or without the guideline.
But basically what will happen then
You
is
can
the
vote
line that it's on will just become a code group. The guideline will.
Right, I guess I just didn't understand that this would be an October 1 change as opposed to a 1/1/27 change.
It's not VUP.
That's why we're talking
issue.
about the line.
Okay.
I move to approve the Ehlers-Danlos syndrome staff proposal.
I have questions about the guideline before we go there.
Okay, we have a motion on the floor.
Scott, or we need a second.
Yeah, do we have a second to the motion?
I'll second. This is Chris.
Chris seconds, so now we'll discuss. Max?
Oh, so for when it says including genetic testing when medically necessary, my understanding was that wasn't a universal recommendation for anybody who potentially guess. Like if they clinically meet for hypermobile, it's not an indication to get genetic testing,
Right,
correct?
one of the criteria, depending on which kind of pathway in that guideline you go through, some of them need genetic tests.
Oh, does the guideline lay it out when to do genetic testing and not? Oh, perfect.
It's
Okay.
correct. And then if you have, for example, I have a patient who has the vascular form, she needed an aorta replacement in
That
a
was
teenager.
supposed to check, I think,
So then they did the genetic test because they were like, what's going on with your cardiovascular system? Found that she had vascular EDS.
Yep.
So she actually kind of even bypasses the guideline. Like,
Oh,
because
yeah.
she already had the genetic test.
Yeah.
So.
And for,
Okay.
I guess I'm struggling with some of the wording in there, because we're saying we're covering things that are medically necessary for the totality of their condition. So that wording to me means based on the diagnosis, not based on the sequelae, but then we just said there aren't approved treatments for the diagnosis.
We say there's no effective treatment for Ehlers-Danlos syndrome.
Right, so why do we say totality of their condition?
So they don't get, if they need the treatment for one of their 5 or 6 conditions, that they get it, even if the doctor put the wrong diagnosis code on the thing.
What?
Like the idea was, if the patient has a symptom of EDS that needs treatment. And is medically necessary for that symptom.
But that's not the
They should get
totality,
that.
that's the symptom, not the totality.
That's the,
That is the
Well-
patient's presenting self.
yeah, so you can look at more than one diagnosis,
I
essentially.
think that kind of
comorbidity.
obfuscates it, and we don't, so like for fibromyalgia, we don't have a guideline out like that, right? It can have,
We don't, correct.
so that seems,
Do we
why
need that
would
word
we
in
talk
there?
them together, because they're sort of inconsistent. I would still leave it at the sequelae, not totality. Because to me, it's confusing to say there isn't an effective treatment, but if we look at things and we add them all up, then there is a treatment.
So, I'm sorry, where does it say totality?
Totality
Mid
of the
second
fourth line
paragraph.
down.
So, oh, appropriate for the patient making the.
I was also trying to get into interactions there.
We could just
Well, we
actually cut it off at multiple manifestations, blah, 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 for which treatment should be covered when medically necessary. We can just cut it off there. I
Medically
like that.
necessary and appropriate.
Yeah, I mean, the part to me is confusing about that is you just told me nothing's medically necessary.
Well, okay, here's
No,
here's
but what
And we
that
don't do
sentence
that for-
says is the joint strain, sprain, dislocation, the cardiovascular problems.
But the joint sprain needs treatment, not the.
Okay,
Yeah.
okay.
The difference is, that so I see a patient who has chronic, patellofemoral instability.
Yeah.
And EDS.
Yep.
I'm gonna send them to PT for quad strengthening for chronic patellofemoral instability.
Yep.
In the setting of EDS, which is clinically irrelevant, because
Right.
it's just gonna change the therapy.
Yep.
To some degree, but the link is to the chronic patellofemoral instability, that's.
And what we're trying to call out
Right.
is, we don't actually treat the EDS, but anything else that you have is true. It's basically stating what we already know is true, but making it more, I think,
Which is fine,
obvious for.
but I think, did you take it out or so?
That,
so
that's,
read
that
that
wording
now.
is.
Right, so then I go, why don't we have that for other similar conditions like that?
Look at that paragraph.
Yeah.
And tell me if that paragraph is the way you want.
There's another part of the paragraph, no. But that sentence.
Do we make these like a sentence with like cerebral palsy or like Downs, like
Yeah,
those
it
were
just
the, those
seems-
are the parallels, or I think as the conversation evolved, like those are the types of parallels where it's not necessarily like diagnosis itself, but it's like all of the cascade and other clinical conditions that need coverage, and so.
I think in this case, because of the concerns from patients and providers, I think calling it out, at least for now, is appropriate. And then if it becomes more, standardized treatment and, people just have, like, we know what to do, then we may rehire the guideline.
I think that's fine, as long as we're kind of explicit on what the difference
I
is.
think
here, 'cause
physical
think there's
therapy
a lot of
request is
overlap.
really common, and again, physical therapy not linked to a specific diagnosis, I think it's really tricky and interminable potentially. While I do think, I have heard from many, many other ALS patients, they really love doing their therapy, there isn't anything, that's specifically tied to muscle strengthening and physical therapy, like that, you can strengthen your muscles after you learn how to from physical therapy or from an exercise program, things like that. So I think it's that delinking of medical physical therapy service from the diagnosis of Ehlers-Danlos without specific condition that physical therapists be treating in addition to their needs.
So the sentence right after that says suspected vascular EDS. If it meets the diagnostic criteria, if it meets the diagnostic criteria, it's not suspected anymore, right? Because that's the diagnostic criteria.
And suspected EDS.
No, because it's known, because it'll have a known genetic marker up at the top of this first paragraph. or otherwise meet criteria. If they're meeting criteria and it's suspected that there's blood, do the test.
Oh, so if they have
And
suspected
echocardiogram.
EDS or if they meet, we just need an or.
So what is suspected EDS? So what is suspected vascular EDS? But then we could go back, test elimination criteria diagnosis. I'm just confused why it says suspected, but they also meet the criteria. It's, if they have it, we should cover monitoring, right? I don't know what suspected.
Suspected vascular complications with their EDS? Because if you have known EDS, the guidelines do say you should
Right.
get.
That's what he's saying,
Right.
that,
Right.
so
So why
after
does-
the yellow where it says patients with suspected,
So
the
just
suspected
remove
seems
suspected?
completely irrelevant.
Okay,
Yeah.
so just.
Because you say suspected and then you say it's diagnosed.
Okay, so if they strike it as suspected, so
Yeah.
patients with vascular EDS should be monitored.
Yeah.
If they meet the diagnostic
There we
criteria, no more than once per year, unless symptomatic. I mean, if you have a patient who has vascular EDS and they had an echo a month ago and now they're in Florida heart failure.
I mean, yeah. Yes, that's the idea. I think it's a smoother sentence if you say patients who meet the diagnostic criteria for vascular EDS get echocardiogram this year, instead of patients who have this, if they.
So just
meet the-
move patients with vascular EDS who meet the criteria.
I'd say patients who meet
Should
the
be
criteria
monitored.
for vascular EDS should be monitored, yeah. I
Yeah,
think
that
it was
would-
written that way because of the suspected. which
Yeah, but
also makes no
that'll
sense.
make it cleaner.
Okay. Who meet. So patients with vascular EDS who meet the 2017 diagnostic criteria should be monitored with echocardiograms no more than once per year unless symptomatic.
Patients who meet the criteria for vascular EDS per the 2017 diagnostic criteria?
I'd say who meet the 2017 diagnostic criteria for vascular EDS.
Patients
Does it have
who,
specific criteria for vascular?
Yes,
yeah,
it's one of the most specific and probably verifiable.
okay, so patients who meet the 2017 diagnostic criteria for vascular EDS should be monitored with echocardiograms no more than once per year unless symptomatic or having known cardiovascular disease. Because of frequent, actually, we don't even have.
Is the known
We
cardiovascular
don't need that.
disease part to acknowledge that they could have a different comorbidity that needs more frequent monitoring?
I think so.
Okay.
And I thought we were gonna refrain from using comorbidity. Comorbidity.
I think it's saying if there's a
Comorbidity.
bunch of other things, just make sure they're not interacting.
Yeah, we're not,
with each
so
other.
comorbidity
not
is
the
a
recovery.
rule,
Not-
we're
not
just
the
using it in
recovery.
the medical, the way doctors talk to each other,
Yeah.
term, not the legal term.
Got it.
Hi, this is Mary. I have a comment at this appropriate time right away.
Of course, no, go ahead.
Now's good.
Thank you. It's a great discussion and really appreciate all of the thoughts on this. So, I do think I'm really glad there's so much concentration on the wording around this. I still, and I understand you've reached out to some experts, I still would like to have a rheumatologist or a neurologist speak to us on this. And the reason is what we're seeing and with consistent record review over the last several years is a massive increase in this diagnosis that at times does not appear substantiated on the notes provided. I can give you an example of a recent one. The patient's cousin thought she's hypermobile, no testing done, received the diagnosis, put on some quite high risk medication. So and this is not unusual. And then what I worry about, and I'm not quite sure what the role of HERC would be with this, but as far as treatment modalities, so what we're seeing is patients being placed on high risk medication that drops their blood pressure, injuries, and then even incredible weakness from orthostatic hypotension, and then they get the diagnosis of POTS and then they end up in wheelchairs. Daily IV infusions, which I'm not aware of any scientific support for that, to the tens of hundreds of patients who are receiving that. Major safety concerns, so obviously 100% uterus very significant diagnosis with vascular and joint complications, and it needs to be appropriately diagnosed and treated. Those are patterns we're seeing very often, the diagnosis being tripled, I guess I could say, with MCAS and POTS when there's no substantiation of either of those or all three. And so I think getting expert consensus on the diagnosis doesn't mean, and I'm a little concerned when the expert who spoke at the last meeting stated during the meeting that they're using different diagnoses to be sure that things get approved, which is its own issue. But I'm very concerned about the massive increase in diagnosis. I would say it's probably, I'm estimating, but I'd really like to know, is probably 20 or 30-fold increase in the diagnosis in the last few years, which seems statistically improbable.
So,
and then with the safety issues regarding the treatment.
So we no longer have the option to not cover diagnoses in 2027. So what I have tried to do with this guideline is to say that you have to document that they meet the 2017 criteria. So if you have a patient with the diagnosis but no documentation of that they meet the criteria and they're requesting inappropriate things, you can deny based on this guideline note.
The other thing I'd say is a lot of those services you described, infusions, medications, are governed by pharmacy criteria, not the HERC guideline per se. And so addressing that, like this guideline specifically talks about looking at comorbidities and interactions of prescribed treatments. And so hopefully that gives some impetus to do that, but it's difficult because each drug class will have its own criteria that were probably made without EDS in mind. And so that'll need to be thought through. I'm not sure what we could do at the HERC level to address that.
And whether it's over or underdiagnosed, all of that, that's outside of our bailiwick as well.
It is, unfortunately.
Well,
So
Mayor, I have similar concerns, but that was, to me, the inclusion of the 2017 criteria. Do you have concerns that those experts might not agree with that diagnostic criteria?
I have concerns that we're not, it's saying even in the notes that it meets the criteria, there's absolutely no evidence that it meets.
Right. Then the documentation does not support the diagnosis, then it's denied. They have to document the pieces of the criteria that meet the diagnosis.
And this guideline note will
It's
support
not,
that.
there's criteria, it's not an opinion.
Yeah, so that you'll have to get a chart note that says the patient had
These
this
things,
gene, or they had this thing, or they had.
Skin laxity, hypermobile joints, certain ones to certain degrees, et cetera. It's
And then,
pretty specific.
and demonstrate those in a physical exam.
Yep.
In my opinion. So we have currently a motion and a second on the table to,
Actually, no, does anyone wanna? Oh,
Give
just
a motion
reviewing.
because we changed it.
Well, you need to
hang
withdraw the
on,
motion.
hang on, we're getting
Yeah.
there. I'm just clarifying where we're at. We have a motion and a second on the table, and now we either need to ask you to modify your motion and or withdraw it if we want to deal with the new stuff, or we can vote on the motion that's currently on the table.
I request to modify motion. My modification is that I move to approve the as amended on the screen, staff recommendation. For
Great.
Ehlers-Danlos syndrome.
And Chris, are you good with seconding the amendment?
I do. Can I just add with the follow-up to maybe look for a consult?
I think that's just direction being given to the staff. We don't need that.
Okay. Then I approve, I second.
Thank you. So now Daphne, will you go around and vote? People can vote as you wish.
Absolutely. Antoinette Awaching,
Yes.
Brian Duty,
Yes.
Mary Beth Angre,
Opposed?
Holly Jo Hodges,
Yes.
Adrian Irwin,
Yes.
Max Kaiser.
Yes.
If Lucy Langer is still skeptical. Lucy, are you there? No. Sarah Love,
Yes.
Chris Pinzon,
Yes.
Katie Shable.
Yes.
Motion passes.
Thank you, and thank you all who came to testify. We need to look at the fibromyalgia. This is a 2027
Okay, so just operationally, do we need to go back and pick up trigger points?
I think we should vote on fibromyalgia since we discussed it, and then we can go back and do trigger. Trigger points is a totally different.
Okay, got
Interrelated but different.
okay. Go ahead.
So the fibromyalgia, I didn't hear a lot of discussion in this group about anything about the staff changes. It's mostly if you're keeping it medical management only except for the chronic pain.
Is there a reason that we are not also identifying diagnostic criteria for fibromyalgia? Because that one was maybe even more debated about what future diagnosis is and is often,
Do you know of diagnostic criteria?
yeah, there's like 4. Because it used to be what, the 11 of 18 points, and then it was kind of changed to a higher experience of pain without some other attributable cause. But I think there's a
What
third one
different,
too.
like, what difference would it make to, coverage decisions, whether or not someone met criteria for fibromyalgia? Do you see treatments that should be denied because they might be harmful, or?
I think, I mean, I think it's a similar discussion around, I haven't seen direct one, but I'm also, we're not looking for that, voting for that, et cetera. I see that diagnosis a lot. That doesn't seem to align with clinical criteria. I'm familiar with both the 10.1 and the more updated, more general diagnosis. And it seems like if we're moving into that territory for other kind of amorphous conditions, there's some debate around it. I think both publicizing and ensuring that we're diagnosing it appropriately is
What
part of our role.
I can do is make a note. We can approve as recommended by staff, and I can make a note to consider writing a guideline.
Yeah.
And get attached.
We were talking about whether there should be similar diagnostic criteria for fibromyalgia.
Yeah. Does that answer your concern?
Yeah. I'm just, my consistent brain. Yeah, it seems simple.
Yeah, and if you approve this, we're in limbo for almost 2 years, so we've
Right.
got a lot of time to work on the details.
Right.
That will go on my work plan list.
Sorry. That one is murky.
Any other comments or concerns? Okay.
So
Yeah,
this change is nothing until 2027? or
Yes, this is a VUP
This is a
item.
VUP.
The guidelines not deleted sooner? Guidelines,
Oh.
the medication guideline?
We should delete the guidelines sooner. That would be a friendly staff amendment to delete guideline note 135, and that would be effective 10/1.
Can you go to that guideline note?
Yes.
Because there's concerns about the opioid statement, right?
That's the,
Well, the whole thing is a clinical practice guideline. There's nothing in here that would be part of like a nurse review for a service. It just says you should treat with 2 or more of the following, and you should do it in primary care.
Well, I'm just wondering, because it made a definitive statement, and use of opioids should be avoided, evidence of harm. Was that not as evidence-based as we had thought?
There's evidence
changed?
about harms. There's a lot of concerns in the patient community about people with fibromyalgia and a second pain condition may be denied opioids for their broken leg or their hip pain or their whatever. whether that's appropriate or not is outside of the scope of the
Do we
literature.
think it's due to that guideline though? I'm just wondering,
Right, well, it's a
That's the
general, it's
concern.
a generalized
Yeah.
statement, you could almost apply to, so many areas and why we're specifically putting it here, right? That seems to be singling out my project. Is the place
Yes.
with a warning about the harms of opioid treatment,
yeah,
we don't put it everywhere.
we also do kind of have the general rule if we're going to, when we take away a statement, it's usually based on some change or new evidence or something like that. So I'm
So
wondering if this was not evidence-based.
basis for that would be, we are not saying you can only have opioids after exercise and cognitive behavioral therapy or whatever else is in the guideline, we're just saying so then if it's just saying there's evidence of harms with opioids and fibromyalgia, then that actually falls into PMT. PMT needs to
okay.
do that
Yeah, that's
review
true.
and they need to say, what's
Okay.
your diagnosis, fibromyalgia, sorry, no, opioids are shown to be harmful.
Okay, that makes a lot more sense. Okay, it's a procedural.
Yeah.
Okay.
I see Sarah Love has her hand raised.
Sarah?
Yeah, real quick. I just had a question on the diagnosis table. Complex regional pain syndrome, should that also be included, the G90.5?
That must be on another line.
Okay, thank you.
Interventions are a little different for PRS.
Yeah.
Yeah, that's on the dysfunction line, so that's already in the funded region.
Okay, thank you.
Okay, other questions, concerns, issues, or
One of the commenters mentioned statement of 5.10.5, it references the P Commission module, and that is actually being updated in the next couple of weeks. I don't see anything that's incompatible. Is that something you want us to look into at all, or are you comfortable with the language that is there in that?
Maybe we should
And
flag it to look at the,
I
consider
actually
the
have
module
been-
once the new module out.
Okay.
Yeah, we can flag it. Jason and I have been help just as outside eyes reviewing it, and I think it's compatible with the statement.
Great, let's, yeah.
I haven't seen
Nice,
the,
but I
like,
have no way of knowing.
I haven't seen the last final version, but those are the ones that I have seen up to now.
That statement is very general, I think kind of in line with common practice, like, I guess I don't quite follow what a conflict is, but
I don't believe there's gonna be any conflict with the
okay,
new.
there's more specifics.
And they're keeping the old as a reference, as a resource.
Right.
They just didn't want providers to have to keep taking the same module to get their license renewed. They wanna give.
So they made a new module?
They want to teach people new things.
Yes.
$8.
You have to make a new one every 2 years by statute.
Hopefully it's updated in the new information, we keep learning.
Just like different actors, different backgrounds.
Okay. This one focuses on a few areas in a little different depth and, but I think the philosophy is not substantially different. Any other, so the modification to this would be that we're deleting the fibromyalgia guideline effective 10/1/25. All the other changes are effective 1/1/27.
The next list updates October.
Correct. And I suppose it would be sooner if we have some huge thing come up that we have to change the list earlier. But we're not having COVID again, ever, no. Mm-mm.
So any other thoughts?
I move to approve these staff recommendations.
As modified.
As modified.
Second by Adrian. And Daphne, if you will roll call this.
I'd be glad to. Antoinette Awachi,
Yes.
Brian Duty,
Yes.
Mary Angre,
Yes.
Adrian Irwin,
Yes.
Max Kaiser.
Yes.
Dr. Langer, are you back? Sarah Love,
Yes.
Chris Pinzon,
Yes.
Katie Shable,
Yes.
Holly Jo Hodges.
Yes.
Motion passes.
All right.
Thank you.
We have one more topic on our agenda, trigger point injections. This was brought to us by our very own Holly Jo Hodges, CCMI director. So trigger point injections involve the injection of saline, anesthetic, or steroids into hyperirritable spot called trigger points. in skeletal muscles. Myofascial pain syndrome is a chronic form of muscle pain that is centered around these trigger points. You can actually sometimes palpate nodules at trigger point areas. Trigger point injections may alleviate pain and restore function by inactivating the trigger points. We talked about this in October. The staff proposal at that time was to add trigger point injection CPT codes and the ICD-10 diagnosis for myofascial pain to the covered back guideline. This body disagreed and recommended pairing these diagnoses on a non-covered line. The members noted that the literature reviewed only supported trigger point injections for acute, less than 6-week duration, myofascial pain, but that the proposed guideline said that you had to have pain present for more than 6 weeks. So basically the proposed guideline didn't match the actual evidence. And HERC staff were also asked to include a definition of trigger point in the proposed guideline and to look at the Medicare LCD for possible wording suggestions. There's several different guidelines. That we reviewed evidence, and when I looked at it again, based on the comments, it is for short-term issues. Most private payers do cover some, they have some coverage for trigger point injection. For trigger point injections, it's considered medically reasonable to treat myofascial pain caused by trigger points when there's a focal area of pain in the skeletal muscle, clinical evidence of trigger point, and find that physical exam finds a hypersensitive bundle or nodule muscle fiber, and non-invasive or conservative therapy is not successful as a first-line treatment. And then they have definite criteria for repeat and trigger point injections. So in summary, one systematic review and meta-analysis found that trigger point injections significantly reduced pain scores when used for acute myofascial pain, which is less than 6 weeks, but noted that there were significant limitations in study design. A systematic review looking at more chronic pain syndromes found there was no evidence that trigger point injections were either beneficial or ineffective. A Cochrane review found that steroid injections were no more effective than saline injections. One expert group recommends that trigger point injections be considered for treatment of patients with myofascial pain as part of a multimodal approach to pain management. Private payers and Medicare are covering trigger point injections for myofascial pain syndrome. And they do require that this is done as part of a comprehensive pain management program. The previous discussion pointed out that the only evidence supporting trigger point injections was for acute or less than 6-week pain. And does note that our guideline, the proposed guideline had to have conservative therapy for more than 6 weeks. So staff is bringing back to you 2 possible options. One, you could determine that trigger point injection has no benefit for chronic pain and put an excluded guideline 2, or determine that trigger point injection should be covered for myofascial pain with a new guideline. And HERC staff no longer recommend including trigger point injections on the back pain line or for back pain without myofascial pain. So the option 1 would be to take the CPT codes out for trigger point injections from their current, they're currently on 4 non-covered lines, and put them into excluded guideline note 2 as having no benefit for chronic pain. Option 2 would be to remove the codes from their 4 current lines that don't have any actual diagnoses that would match, add it to line 597, disorders of soft tissue, adopt a new guideline for trigger point injections. And this would be a unique code grouping in 2027 called conditions treatable by trigger point injections. And it would only include myalgia unspecified site, which is there are 2 diagnoses, myalgia unspecified, myalgia other site, that would be for myofascial pain, and the 2 CPT codes for trigger point injections. The proposed guidelines is based on the Medicare LCD. You have to have myofascial pain syndrome, but with one of those 2 ICD-10 codes caused by trigger points, and then the definition that would be the same as the Medicare definitions. You have to have had failed to have pain improvement after 3 months of conservative therapy that included PT, patient education, and oral medications were clinically appropriate. And trigger point injections are part of an ongoing conservative treatment program, and there's documentation in the medical record of patients actively participating in a rehabilitation program, home exercise program, or functional restoration program, and that the injection includes only anesthetics. And then the repeat trigger point injections in previously injected trigger points are included when all of the following criteria are met. And they have to have at least a 50% response to the first injections. The pain relief has to last at least 6 weeks. They have to have improved functional things on a documented functional scale of at least 50%. They have to be in an ongoing conservative treatment program. The injection includes only anesthetics, and only 3 trigger point injections will be reimbursed per rolling 12-month period.
What page number are we on?
Discussion, 291, basically, looking at the evidence.
Just review our options, yeah.
The evidence, so 1 is excluded and 2 is all the rest of that.
What's excluded or below the line and then covered with below the line now, covered when it gets to above with the guideline.
No, it'd actually be excluded now.
Number 1.
No, number 1's excluded, number
Correct.
2 is
All this
below
other
the line
stuff.
now,
Below the line for the next year and a half.
but in 2027 covered per the guideline.
Right, and it would be a non-funded line, but the exceptions could be made based on the guideline.
Sure. So it's really, are we saying,
So that
if you want above the line and at the medically appropriate rate?
the evidence appears poor. There's little to no long-lasting improvements or benefits. Is that everybody's take?
Yes.
So you're sounding like you're advocating for option 1.
I'm discussing the evidence.
I would advocate for option 1, so I brought it up based on the evidence. Well, I'm
Does anybody else want to talk about their interpretation of the evidence?
Then I would.
Hi, this is
May
Mary.
I-
I agree with that. The effectiveness for, when you look through the evidence, and effectiveness for virtually any indication, it really hasn't been established. You know, most of the studies are doing multiple modalities at a time. It's difficult to sort it out. Yeah, I agree.
This is Chris. And
Yes, Chris.
earlier, Katie had said that sometimes this can be used for like narrowing down diagnostics to figure out where the problems are. Is that different?
Yeah, that's more talking about things like facet injections and.
She's talking more about spinal or
Spinal,
joint issues. This
spine
is
and
soft
joints.
tissue.
Soft,
The depth and size of the needle is significantly different.
Okay, thank you.
It's almost an acupuncture type treatment in terms of, it goes
It
deeper
can
than
be.
acupuncture, but not as deep as like a therapeutic injection that an orthopedist might do.
We didn't get any public comment on this, did we?
We did not.
Sarah, did you look like you want to say something?
No, I mean, this is something I do in my practice as well, but yeah, I mean, you're right. The evidence isn't necessarily there for long-term pain relief, but for short-term, it does work really well.
And what's short term? Hours?
No, weeks.
Okay.
I think these studies that,
And then
but they were still questionable, even for acute.
I don't recall we asked this question during our development. So if you do it short-term, works for several weeks, they come back, you do it again, does it work again? Is that, it's the kind of thing you just have to keep repeating?
Yeah, it does have to be repeated. And like the recommendations, what was that on one of them? Like I agree with the no more than 3 in a 12-month rolling period. I think that's reasonable because sometimes people just like to come in when they don't necessarily need to, and it's not clinically indicated.
Okay, so there's no more discussion. I would entertain
Motion for option 1.
Max, seconded by Katie, a motion to accept, option 1 is written. Any further discussion? If not, Daphne, will you go ahead and take roll call?
You bet. Antoinette Owaki?
Yes.
Sorry.
Yeah.
Brian Duty?
Yes, absent.
Oh, I'm very sorry, I missed that. Mary Beth Andre,
Agree.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
Sarah Love,
Yes.
Chris Penzon,
Yes.
Katie Shable,
Yes.
and last but not least, Holly Joe Hodges.
Yes.
I'm sorry,
Motion
is Dr.
passes.
Langer back?
She and Brian are not.
She's not, okay.
We still have 8. Great. Okay, so we're good. We passed unanimously. Great.
All we have that you guys didn't get through is ophthalmology. You guys rock.
And we're not gonna do that in 8 minutes.
No, we're not. We're not gonna try
I
that.
will move ophthalmology to our March agenda. I also have multiple follow-up issues. Some you will see as consent items. Some of them you may see as a more substantial topic, depending on how I feel like it needs to be dealt with. So those hopefully will be on the March agenda. If not, they'll be on the May agenda.
I was gonna say, our goal is to get as many things on the table as soon as possible. So it may be you don't see them for a couple of meetings for the 2027 stuff. Because we wanna get everything out there and get
I
all
see.
the perspectives on
So it
the
may not come
table.
back in March, it may come back
Yeah, we'll
later
have to-
down the road.
Yeah, and we'll keep that work plan
If
up.
it's something consent, you'll see it in March.
Yeah.
'Cause if it's something where it's gonna be a pretty straightforward discussion, I'd like to discuss it when it's fresh. But
Yes,
if there's
same here.
something in more detail,
That we basically will have to start with anyway, we can push it out. So that makes sense. Try to get as many fresh, new topics out in the ethernet as possible.
yeah, and I think this will really help all of our stakeholders who are really anxious about what's going on with this. I think if we can start whittling away at a lot of things so that people can see kind of what's going on, I think that will be extremely helpful.
I agree.
And staff would really appreciate not having to revisit some of these things.
So any other thoughts or comments about how today went?
Any input on different, anything staff can do differently about how we either present the BUT materials or how we frame things, and you don't have to answer now, you can feel free to send emails, or grab me later and just whisper in my ear.
All right, well, thank you, you guys were great, thank you so much.
I did want to note that nobody
prod you
who
or-
had signed up to give public testimony on Hand of Pans is here.
Yeah, I was gonna say, I was just gonna go, because it's 12:55 just now, so public comment is
there
open public comment.
If there is anyone who is in the virtual meeting who did sign up for public testimony on any topic, please message Daphne, raise your hand, otherwise try to get our attention, and you can have your public testimony time if you still desire to do so.
In the meantime, I'm just gonna chat about the fact that our next meeting will be March 20th. That's a Thursday, same format. Come if you can in person, otherwise we'll have a virtual option. And go from there. So Daphne, any public comments?
No.
And for the record, we have none in the room. Nobody has signed up and there is no public folks in the room, so just notating that, and there's none online. So with that, I think we'll go ahead and adjourn today's meeting. And thanks you all again very much. See you in March. You always do this.
Yay.
All right, sorry about that, Mary, thanks. Gavel in your ear, I'm sorry.
It was so nice to see everyone. I'm gonna not be at the HERC meeting, so I will see you all in March.
Thank you for your help, Daphne.
Bye, see you.
Bye.
So in this question,